Good morning, ladies and gentlemen. We welcome you to the College of Physicians Annual Conference 2020. This year, the Ceylon College of Physicians, in collaboration with the Royal College of Physicians, London, hosts the annual academic sessions themed on transcending boundaries, connecting minds. And today, being the first day of the sessions, we have two pre-congress sessions, and you are at this moment linked with the pre-congress session on frailty and sarcopenia in older adults. And this is done in collaboration with the Sri Lankan Association of Geriatric Medicine. Without much ado, we would like to first call upon Professor Sarath Lekamwasam, who joins us from Karapitiya, Galle, to be a resource person at this program. And we invite you, sir, to welcome
Thank you, Shahan. Can you hear me?
Yes.
I hope you can hear me. Good morning to all of those who are present in the conference venue physically, as well as those who are joining online. As Shahan already said, that there is a joint session between the Sri Lankan College of Physicians as well as the Sri Lankan Geriatric Society of Medicine. Which is actually, we thought that the moving away from the traditional geriatric topics such as the incontinence of urine and dementia and so forth, we will move into certain areas which are really upcoming in geriatric medicine arena. Those include frailty as well as sarcopenia. So I would say that the sarcopenia actually during the recent past, let's say during the last, let's say 5-6 years, has made a lot of advances in the understanding and also in the pathophysiology and so on and so forth. What actually awaits is that the integration that into the clinical medicine. So we'll hear that during the two lectures that how it could be integrated, and the clinicians would hear more about sarcopenia in the management of your patients in the day-to-day practice. Also, that there are two lectures on the frailty, and frailty become an important issue, particularly with the COVID now, and it is used as one of the index in when you are deciding the what shall we say, that the advanced care for the people who are old adults, and then frailty is taken as one of the important factor and deciding whether this patient would be benefited by the advanced care. And finally, we end up the program with a lecture on the fall, which is important, very important domain in the elderly care medicine. So without taking much time, first of all, again, I will welcome all of you and to this pre-congress, and I hope that you will enjoy the presentations, and so that you would take some messages home, and then that you will improve your clinical practice in the light of these what take place today. So over to you, Shahan, again.
Thank you, sir. That was Professor Sarath Lekamwasam, President of the Sri Lankan Association of Geriatric Medicine. I would like to now call upon Dr. Achala Balasurya. She was the founder secretary of the Sri Lanka Association of Geriatric Medicine and is also the president-elect of the association. And we will now move on to the first segment of this pre-congress, which will be themed on sarcopenia.
Good morning to all of you. I welcome you again to the pre-congress on geriatric medicine. Now, our first speaker, Professor Sarath Lekamwasam, will be speaking to us on introduction of definition and diagnosis of sarcopenia. He is Professor Lekamvasam's lecture will be is a recorded presentation as he is unable to come in person due to unavoidable reasons. Professor Lekamvasam is incumbent president of the Sri Lankan Association of Geriatric Medicine, and he is a professor of medicine at Faculty of Medicine, Galle. Now let's play Professor Lekamvasam's recorded presentation, please.
Good morning, everybody. And first of all, let me thank the Ceylon College of Physicians for inviting me to do this particular lecture, the pre-congress, and also allowing us to have this pre-congress in their main program, because this is actually a collaboration between the Sri Lankan Geriatric Association with the Ceylon College of Physicians. So when I informed the president of the Ceylon College of Physicians that, I'm the Sri Lankan Geriatric Association is thinking of doing a joint collaboration session, and he was very happily and very enthusiastically gave me this pre-congress, and then I should be very thankful to him. In this particular pre-congress, we address certain issues which are particularly seen in older adults. And I will begin with sarcopenia and diagnosis and the definition. And then this will be followed by another lecture on sarcopenia, and particularly about the investigations and the management aspect of it. I should declare that I have no conflicts of interest about this topic. And word sarcopenia, I know it's a relatively new topic in Sri Lanka, but actually it came from the very, very old listing and a great Greek word sarx, and that means flesh, and penia means loss. So it's a loss of flesh. That is so at the very beginning, 1989, that people thought that it's due to a loss of skeletal muscle mass and the size. So they were mainly talking about the loss of muscle mass and the muscle size. So if you first look at the very briefly, just one slide that the causes of sarcopenia that that can be divided into what's called primary, which is age-related generally, and secondary, which can be various things like activity-related, disease-related, nutrition-related, and it can be many other types as well. But if you look at the consequence of sarcopenia, why we are worried about it actually is the loss of muscles and strength and function particularly, and will increase the risk of falls and disability, mortality, loss of dependence actually, independence, and also mobility. So there's a lot of what I call clinical outcomes that are attached to sarcopenia, and we seems to see all these in our clinical practice, though we do not actually particularly realize this fact. But then sarcopenia is not uncommon in clinical practice. Just very briefly about the prevalence of sarcopenia, because if you talk about people more than 65, and then you find 1/4 of those people have got sarcopenia, and the studies have shown that the prevalence increases very rapidly. And then if you talk about the people more than 80 years, and then nearly about 60% of those people have got sarcopenia. So we are talking about the condition which is quite prevalent. Now, the sarcopenia whole thing started actually completely change into a different direction with this particular group of people, what is called European Working Group on Sarcopenia in older people. And they first met in 2010, that is called the EWGSOP1. And then there are the people actually who for the first time met and then, put their heads together and then, trying to develop what's called a little bit of a work in definition, and then also say how it should be diagnosed and all. And you can see the effect of that, immediate effect of that actually. You can see that the research related to sarcopenia from 1993 up to 2020, I just got this slide made this morning, and you can see up until about 2010, and very little research into that. But then once these people gave a work in definition, and also kind of platform to make the uniform make the diagnosis uniform, and you can see that there's exponential rise in the research related to sarcopenia in this world. So it is very much like osteoporosis in 1994, that somebody gave a definition of osteoporosis, and then from there onward the research actually took off very rapidly. So people were actually waiting for a definition and then some kind of a working platform. Now, these are the two articles that I'll be talking about. There's the Sarcopenia, the first one in 2010, and then there's another one, 2019. So should start with what they have said in 2010, and then you're going to forget about that actually altogether, and then you're going to actually walk away with what I'm saying about 2019, and that is what's called what are currently applicable. There are outside the European working group, there are other groups as well, like International Working Group and Asian Group, and then so you can see getting bit widespread now. If you look at the definition of sarcopenia, it's quite a verbose actually. It's a syndrome characterized by progressive loss of muscle mass, muscle strength, and the physical performance. So you can see immediately from that actually Greek what is called the concept, and immediately that you can see that apart from the muscle mass, and people have inserted muscle strength and the physical performance in the definition, saying that there are other what I call attributes in the muscle that should be taken into account when you get this definition. Because if you read the muscle mass is not the only thing. This is how the age-related loss of muscle mass, and we have demonstrated that in our research and all. And but if you look at that actually with the loss of muscle strength and the muscle function, and they are not parallel. So there's no parallelism between the loss of muscle mass and the loss of muscle function and the loss of muscle strength. They are not really parallel, and they can be affected to various extent, and then that is why all three should be there in the definition. Now then this particular group, European group, met in 2010, and for the first time what they say that we will include the muscle mass, muscle strength, and the muscle performance, and that they had all three components related to a muscle when you start working. So based on that, they got these what are called three concepts. I think actually they are following very much like osteoporosis, like a normal osteopenia, osteoporosis, that type of thing. And they say if just a mere loss of muscle mass, and then you'll call it what's called pre-sarcopenia. But with the loss of muscle mass, you get either muscle strength, loss of muscle strength, or a poor muscle performance, and then you can say sarcopenia. Sarcopenia requires in addition to muscle mass loss, impairment of the other two, one of the other, like muscle strength or performance. But of all three components are impaired, like a mass strength and the performance, and then of course they got severe sarcopenia. So that's the definition. But you can just remember that. But then probably you have to forget that, because the newer definition is completely different. Now, one of the drawback in this definition that people later realize is that the muscle mass has been given a lot of importance, and if you can see the other two determination of the two is quite easy, is relatively easy determination of the rather than determination of muscle mass. So the people actually in the first time that they met in 2010, they were going behind the muscle mass and too much muscle mass involvement in the definition. And later people started working on to realize that, only certain centers could do that. But all the centers could do what is called muscle strength and muscle performance much more easier. So when we got this algorithm, they developed this algorithm and all that, for the diagnosis. So they picked up this what's called muscle speed and also muscle strength, so gait speed and the grip strength. And then, but for the definition, you always record what is called the measure of muscle mass. That is required for you to make a diagnosis. For example, that if the gait speed is impaired, and then you need to measure the muscle mass in order to come to a diagnosis of sarcopenia. And if the gait speed is preserved, and then you check the grip strength, and if it is impaired, and again you need to measure the muscle mass in order to confirm the diagnosis of sarcopenia. So sarcopenia diagnosis actually and came through this pathway, and the measuring the muscle mass was one of the important components that all in all those algorithms. And the same thing in other way, but I don't want to duplicate it. And also they gave what are the kind of measures that you can take in order to measure these things, like a muscle mass under research setting, what can be done, and also clinical setting, what can be done. I'll be here talking more with what was the clinical practice rather than the research setting. Bioimpedance technology, and then there is we use sometimes in our patient, and the DEXA and the anthropometry are the ones that we can use to detect the muscle mass. And I will come to that anthropometry in a little while. If you're looking at the what's called muscle strength and then the hand grip strength, that can be very easily measured with a small gadget that is the one that you use. The physical performance, of course, your also get up and go test is the one which is quite useful, but there are other ones like usual gait speed, and then those also can be easily used. So those also handleable and then manageable measures that you can take apart from the first lot. So also that the 2010 meeting recommended using what are called normative references, and then the references they should be so kind of the population specific. So using healthy young adults and then taking the two standard deviation cutoff value from the mean, and then you can get you asked to get your normative references that you have done. But then the recent evaluation, what people realized during 9 years from 2000 to 2019, now it actually got included into what is called the ICD diagnosis code, and then with a particular this code number. But then people realized that the integration of sarcopenia into clinical practice, despite giving us a kind of uniform diagnosis and also sort of pathway to make a diagnosis, is very poor. And then it doesn't get integrated into clinical practice, and the clinicians do not actually regard completely disregard this. So their main concern was in the second meeting was to emphasize that the clinician have opportunities preventing, delaying, treating, and sometimes even reversing sarcopenia, and these opportunities are not actually grabbed. And then how are you going to encourage clinicians to do that? And then if you want to do that, and you must make it always clinician friendly. Now in the second meeting, actually, low muscle strength was given priority over muscle mass. So it's a little actually turned around actually. And what they did say that the muscle strength is more important than the muscle mass. So they took it actually out, and then the muscle mass is little lower, given a little lower position. So if your muscle strength is impaired, if you get somebody else or muscle strength is impaired, and you can say this patient got a probable sarcopenia. Now, if you can add that, muscle mass into that, and then you can say you can diagnose sarcopenia. So sarcopenia diagnosis, I'll come to again say probable sarcopenia is a condition that clinician can look for because that is sufficient enough to trigger your, let's say, investigation and treatment. You can do that with your probable sarcopenia diagnosis. Now, probable sarcopenia is identified the criterion 1, that is a low muscle strength, and also a diagnosis confirmed by additional documentation criterion 2. So if you got a what's called the muscle strength impairment, plus if you can demonstrate that there's a muscle quantity and the quality impairment, and then you have fulfilled criteria to diagnose sarcopenia here. What I'm trying to tell is the clinician if the clinician has no facilities to quantify the muscle mass, and he should not actually say that I can do that or something like that, because the criterion 1 can be used and the probable sarcopenia is good enough to start acting. So if all three criteria again met, then of course, sarcopenia is considered to be severe like a previous one. So when you look at the what is called the clinical pathways, and again now they changed that little bit because they recommended what is called the SARC-F questionnaire as a screening tool. And this particular questionnaire has only 5 questions that you ask, all about the performance of the strength of the muscles and the functions of the muscles. And depending on that score, that you can perhaps think that this patient has sarcopenia or patient does not have sarcopenia or need further investigation. So if your clinical practice, because earlier you gave what is called grip strength as a indicator or measurement of the muscle strength, but then they added another one, what is called chair stand test and chair rise test. That is, you stand and sit and 5 times and sit and stand in a chair, and then that is also a useful test. In order to, as what is called a muscle quantity and a muscle quality, and they have again introduced what is called the, these are the measurement that they included. I'm not going to go a lot of details into that. And what we use in our research is the ASMM, Musculoskeletal muscle mass, and detect by dual energy absorptiometry. And there are other like impedance, and also CT, quantitative CT or MRI also can be used. And if you take cross section across a lumbar muscle, and that also can be used. The physical performance, again, they expanded, like, gait speed, time to up and go test, good old test that, that people have a lot of faith on that. And also 4-meter walk or long distance corridor walk, they all can be used to check the physical performance. Now, this is one of the major recommendations that came from this particular working group, and what is called FACS approach, what is called find, assess, confirm the severity, and then clinical practice is quite a useful thing. So actually, when we look at that, this is something that we can always adopt in our clinical practice. The find cases for which you need only a SARC-F questionnaire, and if the questionnaire says that it is questionnaire patient says normal, and then no sarcopenia, you can rescreen after 1 year, so you don't have to worry. Let's say that patient is positive for this screening, and then you can check the muscle strength by grip strength or the chair stand test that is manageable, that you can do in the clinical setting. And if that is low, then you can do what is called condition called sarcopenia probable. And what is important is that in clinical practice, this is sufficient enough to trigger assessment and the management. And then you don't have to actually wait to confirm sarcopenia. It is like, finding a vertebral fracture in osteoporosis. You don't have to go for a DEXA scan, and you can certainly, that can trigger your assessment, and treatment is something very much similar to that. But if you have facilities, then you can go beyond that. You can assess the muscle quantity or quality. And then if there is a low, then sarcopenia is confirmed. And then you are in a, let's say, a more firmer ground. And then if there is low, then of course you can go to what's called physical performance, and then you can get sarcopenia severe. But that's very much academic. But if you're a clinician, you can certainly stop at here, and then you can start treating your patients. This is something that you change that particular classification given earlier. So you have changed it now. Muscle strength here is given more weightage than the muscle mass here. So cutoff values also, they recommended that, need to be population specific, because the population, they change from the nutrition, height and weight and all that, because of that, population specific. And also they said that, instead of -2, -2, and they take -2.5, and it's a more conservative approach. And so now people, we actually develop in -2, and our cutoff value for Sri Lanka, but then, people must be using -2.5 now. Just to show you 2 publications that we have done. Actually, what we have done, development cross-validation of anthropometric predictive models to estimate appendiculoskeletal muscle mass in middle-aged women in Sri Lanka. And then what we did is actually we developed 2 models, and which are based on the height, weight, and skin fold thickness. And then they're fantastic. They just work, and very, very accurate in estimating what's called muscle mass in middle-aged women in Sri Lanka. We had just extended the study to what's called the elderly, older people more than 65 years. And we found that these equations, they work very fine, and that is a waiting publication. So if somebody is interested, they can always use these anthropometric predictive models in order to check the muscle mass, and you don't have to wait for a DEXA for that. The cutoff values for determination of sarcopenia in Sri Lanka, we have got these cutoff values, and that also has been published in the CMJ this time. So in summary, what I should say is that sarcopenia is not a rare condition in clinical practice. Only thing is that we tend to overlook it. It is done in the patients with diabetes, and very much it is in the patient with, let's say, kidney disease, and also it is very much in the patients who have got what is called the chronic lung disease. And we know that, we knew that was that the patients who have got a chronic obstructive airway disease, the moment they get a muscle mass impairment of their muscle functions, and they go down very quickly, and they deteriorate because they lose the muscle mass and they lose the respiratory effort. And as a result of that, their clinical deterioration is very rapid. We knew that. And so now there's an opportunity for us to detect it a little early and make sure that, you don't allow that situation to occur. And a lot of attempts there are to integrate sarcopenia into clinical medicine. And I'm sure in time to come, let's say 5 years down the line, clinicians will be talking about sarcopenia, because now I got a way to detect that at the bedside. And so that, that will be additional component added to the patient's management, that, apart from that, let's say, looking after various other things like, it's another component that people will be interested in the management of these patients. And for which actually FSCS approach concept would be one of the useful thing, and where it is immediately applicable in the clinical setting. So clinician would be sort of working more likely with what's called probable sarcopenia, and there's no actually what shall we say, excuse for somebody to ignore that, because it's a very easily detectable condition in a clinical setting. And sarcopenia in some settings, and when the facilities are available for someone to detect muscle mass, but even then you can use equations, and if you use equations you can get a muscle mass. So that is and we found that it's a very little difference between what is called the measured muscle mass with the DEXA and the estimated muscle mass with the equations, and they work very fine, and the accuracy doesn't seems to be quite different. So the accuracy error seems to be minimal, and then as a result you can use these. So that's my last slides. So thank you very much. So I would like to see that, people talking about sarcopenia in their patient management in years to come, and particularly when you come to patients with the chronic diseases and the patients who are particularly older than 65 years. Thank you.
Thank you, sir, for that elaborative lecture on definition and diagnosis of sarcopenia. Now we move on to the second speech. Our second speaker will speak to us on clinical application and management of sarcopenia. Our second speaker is actually Dr. Shehandi Silva, Senior Lecturer in Medicine at the University of Sri Jayawardhanapura, and he's also a consultant physician to Colombo South Teaching Hospital. He's currently the Secretary of the Sri Lankan Association of Geriatric Medicine. We will have the question and answer session at the end of Dr. Shehan Silva's speech. Over to you, Shehan.
Thank you, Madam. Good morning again, ladies and gentlemen. Indeed a privilege to speak a few words or have a talk on clinical application and management of sarcopenia after Professor Lekamvasam's introduction to this new entity. So there are no conflicts of interest with regards to my presentation. And I start off with this quotation, which I suppose most of you would know, the 7 ages of man. And we talk about, Shakespeare talks about the last scene of all, the second childishness and mere oblivion, where there is no teeth, no eyes, or no vision, no taste, and nothing. So this is the understanding that we have about aging, but is that so? We don't try to add more years to life, but we should add more life to our years, ourselves as well as our patients. So the outline of my talk will be on the differential diagnosis of sarcopenia and the coexisting similarities. To talk about the pathophysiology of sarcopenia in relation to clinical application. I suppose it's essential that we know the introductory specialties, biochemistry and physiology, when it comes to clinical medicine. So sarcopenia is no exception. And also to speak about non-pharmacological modalities and also the pharmacological modalities that are available. So weight loss, especially in older adults, how do we categorize it? So one may voluntarily lose weight, as in restricting food, going on a diet, or engaging in strenuous activity or exercise. But what is abnormal is when there is no control by that patient or the person, when it is involuntary, and that succumbs to malnutrition or starvation, cachexia, or sarcopenia. So these are the 3 important areas that I would like to highlight. So other than sarcopenia, it's essential that we have to understand that these other 2 entities, malnutrition and cachexia, can exist, and they can also exist in cohabitation. As you know, malnutrition is where there is pure protein and energy deficiency, which results in reduction of both fat and lean mass. Cachexia again is a state where there is reduction of both fat as well as lean mass, but here we see that there is a secondary entity, maybe a wasting disease like a cancer, chronic disease, or immunity deficiency like HIV. So we see that there is a significant weight loss. There's reduction of food intake, severe anorexia, loss of appetite, and there is systemic inflammation. Sarcopenia, as highlighted in the previous presentation, there's reduction of lean mass with increment of fat. And this is attributed to disuse, inadequate diet, or hormonal regulation, in addition to the normal aging process, which we call as primary sarcopenia. So it's essential that we understand that there is an overlap of sarcopenia and cachexia. But there are some subtle changes that are there between these two entities, where you see that although protein synthesis in the muscles are low in both entities, there is more degradation or destruction of muscles in cachexia because of the inflammatory response. In sarcopenia, the muscle degradation is not changed, but there is reduction of muscle synthesis. In both conditions, the strength and functions are decreased. Of course, in sarcopenia, you see that there's increment of fat mass. And in cachexia, you see that there is increase of the metabolism, catabolism, and there is increased energy expenditure. Then there is a greatly elevated state of inflammation in cachexia in comparison to sarcopenia. Sarcopenia also has increased inflammation. There's also an entity called sarcopenic obesity. You may think that sarcopenic patients are just wasted, thin, lemon on stick appearance sort of, that they are matchstick individuals. But then again, there can be an entity where patients can be obese while being sarcopenic. So you see that there are two diagrams in the slide. You see that obesity can have with different levels of lean mass. And you see that the BMI may be the same, but the lean mass is different. And more the fat is in consideration to lean mass, they are sarcopenic obese. In the same way, patients can have different BMIs, but they can have low lean mass, the same lean mass. So this is attributed to excess calorie intake and reduced physical inactivity, which is also contributed by the non-communicable diseases. So you see that you need a lot of active muscles to move the large body fat. So how do we deal with it? We need to address diet-induced weight loss, that is in calories, along with regular exercise. We'll come to that later. There's also an entity where, just like osteopenia, where there is age-related loss of bone mass and quality and strength, you see that sarcopenia is age-related loss of mass, muscle mass, and strength. So these two entities, the bones and the muscles, they can both coexist. And you see that there's an entity called osteosarcopenia. Please do not miss the presence of this, the other entity when you're thinking about your patients, because you see that both of these contribute to increased risk of fractures, increased risk of falls. So coming to the crux of our talk, there are several modalities of management, which include exercise, nutrition, and pharmacological agents. But before we go on to that, it's essential that we know a little bit about the muscles. Muscles are heterogeneous structures which are composed of type 1 and type 2 fibers. Type 1 fibers are small in size, whereas type 2 are large. And type 1 have slow activity, whereas in type 2 muscles, there's fast resistance to fatigue and engaging in demanding tasks and powerful tasks. Whereas slow muscles or fibers or type 1 fibers have a controlled contraction, especially when you initiate a particular movement. So in sarcopenia, the pathology is based on multiple entities. These include oxidative changes, changes in hormones, changes in the mitochondria, inactivity as we spoke of, the protein metabolism imbalances, inflammation, etc. So it's a multiple multi-factorial involvement. So on your left side, you see the young muscles which have particularly equal amount of type 1 and type 2 fibers. And as you age, you see that the type 2 fibers are reduced in number, and it's type 1 fibers that are predominant. Mind you, you see also that in aging, that the type 2 fibers become smaller in size. As I mentioned before, type 2 fibers are large diameter, cross-sectional area containing fibers, but with aging, they shrink. And in sarcopenia seed, you see that there's a marked change in this phenomenon, where there's marked loss of type 2 fibers, which are the strong fibers, which need the demand contraction, and the quality of the type 2 fibers are also reduced. So I go back to Professor Lekamwasam's talk. So sarcopenia is reduction in size, as the mass, as well as the strength or the function. When you talk about muscle injury, there are some cells called satellite cells, which are primitive cells that are there in the muscles, which get activated with with injury as well as exercise, which differentiate into muscle cells or myoblasts and myocytes, and they fill in the gaps. So it's also found out that sarcopenia is caused in failure by partly by the failure of the satellite cell activation. We'll come to that when we talk about management. So in management, it is essential that we think about the secondary causes of sarcopenia. So secondary causes of sarcopenia include reduced activity, bed rest, sedentary life, and deconditioning. In hospital, you get a patient who comes across a stroke, and then patient is bedbound, and every day you see that there is muscle wasting because of the inactivity, the sedentary state, and there is deconditioning. Sarcopenia is also caused by disease-related activities like organ failure because of inflammatory diseases, malignancies, and also various endocrinological diseases like thyrotoxicosis and Cushing's syndrome, and also poor nutrition, whether it be due to anorexia, whether it be because of poor absorption or digestion in the GI tract. We tend to forget another area, Ayatogenesis, what we do to the patient. We hospitalize the patient. We keep them on bed rest. We do not mobilize them. We give them medication. We induce anorexia. We give a very limited space for them to be in the hospital. And all of these contribute to secondary sarcopenia as well. Please be mindful of this green square that I have depicted. So coming back, so management includes exercise, nutrition, and pharmacological agents. We deal with exercise. Exercise is a very important entity. In terms of exercise physiology and exercise medicine, sports medicine, there are two types of exercise. That's resistance as well as aerobic exercise. Resistance exercise is also known as strength training, where the goal is to increase the strength and the resistance to endure a particular load. And these include things like weightlifting, stretching, etc. And by engaging resistance exercise, there is increase of functioning mitochondria. Whereas in aerobic or endurance exercise, as in what we usually do, we walk, we jog, we swim, we cycle, there is an increased number of mitochondria. So you see that there is a difference, the function of the mitochondria and the number of the mitochondria. So quality of a muscle is the strength which is adjusted to muscle mass. And the strength that we think about, we expect, is based on a triple approach: the mass, the quality, and the motor neuronal adaptation, what the reflexes to the muscles are generated as. So in resistance exercise, it is shown that muscle mass, strength, and the quality improves significantly in older adults. This also includes the neuromuscular functions that I spoke of, which models or there is modeling of the muscles, maintaining the integrity and the strength of the muscles. And also weightlifting has been shown to show myofibrillary protein synthesis, increase of myofibrillary protein synthesis and muscle mass and strength in older adults. And the American College of Sports Medicine have put out a statement after their research initially in 10 years back, that training at 70 to 90% of one repetition maximum for more than 2 days per week will be appropriate to train and to gain muscle size and strength even in the frail. We'll talk about what a repetition and what exercise prescription is in a little while. So resistant training in older adults increase the strength, although it is low in absolute terms, especially in older adult. You see that there is similar outcomes relative to muscle mass, and there is increased size of muscle. So the benefit of resistant training is there even with one dedicated program per week. What about aerobic training? We all like aerobic training instead of resistant training. We don't like to stay in one place and do exercise, right? I'm not talking about jogging on a treadmill, but let's say weightlifting or stretching exercise. Because we want to move. People like to move about, and that's a more appealing thing. So although it is more appealing, resistance training is more beneficial. But aerobic training causes more muscle, synthesis, satellite cell activation, and increased muscle fiber areas. But the muscle hypertrophy or increase in the size of the muscle is less than that of resistive exercise. But aerobic training has an advantage, especially in persons who have sarcopenic obesity. It is very useful to reduce the body fat, including the intramuscular fat. So how do we prescribe resistant exercise to our patients or to even our elders, our very own people? So 2 to 3 days of non-consecutive days of exercise, resistance exercise per week is adequate, because you need to have a break to help the muscle to repair and rebuild. And when you talk about resistance exercise or any kind of exercise, you have two concepts. You have a repetition. A repetition is a complete movement. Let's say you flex the muscle and you extend the muscle and you flex the muscle. So that is one cycle. That is a repetition. A set is a group of repetitions. So if you do 10 extension and flexion cycles, so you get one set of 10 repetitions. So let's say you are a new exerciser and you prescribe it to a frail older adult. You would start with one set which has 10 to 15 repetition of each of those thought movements. And you start with a lighter weight. You gradually increase it to up to about 20 sets as the patient or the person is comfortable. But when you increase the sets, you reduce the repetitions to a small amount. This is to engage higher strength with greater load. It's essential that with each set that you tell the patient to rest for 2 to 3 minutes. Rest is essential as well as exercise. And it is essential that the rhythm of the exercise is taught as 3 seconds to effort, 1 second to keep the load, and 3 seconds to return it back. So you start off with the chest, shoulder, arms, back for the upper body, and the lower back, abdomen, hip, and legs. Start with the largest and the strongest group, and then you engage on the other weaker muscles as you go on, as the body becomes toned. You can use dumbbells, machines, resistive bands. You can tell the patient to use the patient's own body. Sandbags, these are economical. Or even things like cans, water bottles, or any kind of loads that are safe for the patient. So you start low and go slow. This is an important adage in geriatric medicine. Start low and go slow. But with regards to socioeconomic constraint, be innovative, be opportunistic. So aerobic and resistance exercise improve balance, lessens fatigue, increase the pain sensitivity, reduces the cardiovascular risk, and improves appetite. But out of both, resistance training is the best. So where does this correlate to? So this is a very simplified pathway of muscle gain and loss. You see that exercise activates the mTOR, or the mammalian target of rapamycin, which is a genetic activator to increase the protein synthesis and the satellite cell proliferation that we spoke of. You see that leucine, an amino acid, also activates this mTOR, the one that I have depicted in red, in protein synthesis. So this is where nutrition also comes into play. So protein intake is essential. It is a barrier in increasing the muscle tissue and strength when somebody is engaging resistance exercise. Supplementation in absence of malnutrition has been shown to be unsuccessful. And it is essential to know that adequate number of calories are provided, not in excess, to prevent the loss of muscle, as shown in studies. So the normal protein intake of older adults is deemed as 0.8 grams per kilogram per day. But recent studies have recommended even to stretch it up to 1 or 1.2 grams per kilogram per body weight per day. So if it is even more frail, you can go up to a higher dose, higher quantity of proteins. Less calories, more proteins. So please engage your nutrition specialists, nutritionists, when you are prescribing this. It is essential that you give some advice also. Essential amino acids such as leucine have shown that there is anabolic effect, and there is more synthesis of muscle proteins, which is similar to older, similar in older and younger adults, but of course in older adults it's delayed. Leucine, how does it act? It stimulates the muscle protein synthesis by initiation of mRNA translation, if you can remember your biochemistry. And it has shown to be very useful. So supplementation with whey protein, which is a rich source of leucine, has been shown to prevent sarcopenia. Of course, larger studies are needed. So these are some of the important food items that can be used to nutritionally fortify this. So of course, you see that whey proteins have 10 grams per 100 grams. Whey protein is the remnant of milk that is after curdling. In Sinhala, we call it moru. After the milk is curdled or clotted, what is remnant is high in consistency with leucine. Of course, you see that there are other options like soya beans. If you are a meat eater, red meat, be mindful of lipids though. Fish, egg, dal, lentils, and even things like chickpeas, which are, these things are available. It's a part to fortify the diet and to improve the reversible causes of anorexia in an older adult. A few words about HMB, or hydroxymethyl-butyric acid beta component. It is a metabolite of leucine, and it is also an agent that stimulates mTOR. And you see that in the market that there are so many protein supplements that have HMB. Of course, there is more research needed in older age group. You don't have to prescribe these things. You can fortify the diet with what is available. So diet and exercise go hand in hand. There's a synergistic approach, and they have found out that there is a synergistic approach in improving the muscle mass and the function. Of course, the long-term effects of this are uncertain, but there is some good hope. Recently, there was a large study done in Europe called the SPRINT trial, which was concluded, and results are waiting, and most probably the results are results will be acceptable. Coming to pharmacological treatment, this is a very gray area in geriatrics as well as in terms of sarcopenia. There are no specific drugs that have been attributed for treatment of sarcopenia, and there are multiple systemic reviews and meta-analysis that have been focused on this. There's a lot of scope that needs to be done. One attributable agent that has been spoken of is testosterone. You see that athletes use this, as well as this dihydroepiandrosterone, DHAES. As you age, you tend to lose your testosterone, and there is association of low muscle mass and strength and function with testosterone. So you see that testosterone increases the muscle mass and strength when given on a higher dose in young adults when they are engaged in resistance training. This is because of the activation of the satellite cells. But such doses are not given in older adults because of side effects. We'll talk about that. And the anabolic effects on lean muscle and strength, mass and strength in older adults is shown to be weaker. And DHAE does not appear to show any benefit in physical function or performance. So the side effects of testosterone are that it increases the PSA, causes prostatic hyperplasia. There may be a risk of prostatic CA. There is an increased load of red cells, and there is also increased risk of cardiovascular disease. So testosterone is not advocated, and there is no consensus at this time. Estrogen. You see that estrogen is important in reducing the pro-inflammatory cytokines. In sarcopenia, one deals with TNF-alpha and interleukin-6, which induce sarcopenia. In laboratory studies, it has been shown that estrogens have a role in this, but there is no study that have confirmed positive findings in older adults. Growth hormone, again, shown to increase muscle strength and mass, but it has not been, there's no level 1 evidence that growth hormone deficiency older adults have increments of muscle mass and strength with resistance training. And of course, after growth hormone, there's increase of insulin-like growth factor, which correlates with the increased risk of solid organ malignancies. So therefore, growth hormone is not part of consensus. Vitamin D has been shown to, deficiency has been shown to reduce, vitamin D deficiency has shown to be associated with risk of hip fractures, especially in community and nursing home adults. And there is some scope that giving vitamin D will improve the muscle mass and functions. And it is worthwhile exploring the possibility that the patient may be vitamin D deficient because there is associated muscle atrophy, especially the type 2 fibers. Very important drug in terms of medicine, angiotensin converting enzyme inhibitors as well as angiotensin receptor blockers. So they may be involved in the activation of the renin-angiotensin system, may be involved in progress of sarcopenia because of there is increased cytokine production. And lab studies have shown that giving angiotensin 2 increases the muscle atrophy, the metabolic and the inflammatory pathways. Therefore, is there a place in giving ACE inhibitors and ARBs? This is also something in discussion. Omega-3 fatty acids, something that is very much spoken of these days. Epidemiological studies have shown that fatty fish may prevent sarcopenia. This is because of the anti-inflammatory effects of omega-3. Only one study has shown that there is no effect on muscle mass or muscle strength. but there is some evidence that omega-3 fatty acids take a role. Creatine, widely used by bodybuilders as a bodybuilding substance. It increases the energy store by increasing the intramuscular phosphocreatinine. And in young adults, it's shown that exercise performance is increased, but there's mixed results in muscle mass and strength in sarcopenia. Then we come on to a few slides. These are things that will come up in the future. Cytokine inhibitors, such as thalidomide, which is not used at the moment, which inhibits the TNF-alpha activity. This is in relation to studies that have been done in rheumatoid arthritis patients, where they're shown to improve sarcopenia. But the benefit-risk balance is a big consideration. So you see that there is this thing called myostatin, which inhibits the satellite cell proliferation. And this is indeed the place where ammonia, which is increased in chronic liver disease, chronic liver cell disease, which causes cirrhosis associated cachexia as well as sarcopenia. So myostatin is also a target where there are drugs that have been devised to inhibit or counteract the myostatin activities. These are monoclonal antibodies. These will be also spoken of in the future. There's also a place for a receptor called activin receptor blockade. And again, these are monoclonal antibodies. There are miscellaneous agents which are in the limelight, such as, just like SERMs, selective estrogen receptor modulators, there are drugs called SARMs, selective androgen receptor modulators, which can improve sarcopenia. And also this hunger hormone called ghrelin, right? There is research into this, that it will improve sarcopenia, but none of these are still in consensus. Can we take a pill and evade exercise? So this is again an area that is coming up. So just to pop in a pill which will mimic exercise. And mind you, metformin has also shown some scope of having the property of an exercise mimetic. Statins, mixed opinions. Statins are shown to have associated with decline in muscle strength and increased risk of falls. But there's now a consensus that statin can increase the appendicular mass and after resistance training. Of course, further studies are needed to assess this. Of course, there's a whole heap of natural substances. What is essential is, after you deal with the exercise and nutrition tackling, which is possible in our setup, you need to assess the decline in function and strength. Frailty assessment is essential, and I think this will be dealt in the next hour or so of our program. Assessment of daily living, activities of daily living, etc. The falls risks have to be done. Check on the gait, the transference, the ability to move from the chair to the bed, from the bed to the chair, etc. Whether there's coordination, whether there's presence of multimorbidity, and the important thing I highlight, polypharmacy. Is it rational? Encourage activities without a strain or pain. Start low, go slow, be opportunistic, be innovative. And exercise should be adjusted, should be practical in terms of multimorbidity and functional status. And encourage mobility. There should be advice on good nutrition. I won't delve on this. It's essential that, I think Dr. Dilha will be talking more on this. It's essential that we start now, because delaying things is the thief of time. The best time to plant a tree was 20 years ago, but the second best time is now. It's essential that we know. So in conclusion, sarcopenia can be present as an overlap with cachexia and malnutrition. we need to address secondary causes of sarcopenia and other mimics when we are thinking about a frail elderly patient. Strength training exercise is effective in improving muscle mass and strength. Fortify the diet with increased proteins, especially ones that have more leucine. Reduce the number of calories. Pharmacological approach has shown some evidence, but more studies are needed. Prevention is essential. Thank you.
Thank you, Dr. Shehan, for that very detailed and impressive presentation. Now the session is open for questions. We have about 15 minutes. We welcome questions from the audience.
So vitamin D has been shown to be associated with reduced muscle mass and strength, and there are some epidemiological studies that have been shown to be deemed with vitamin D deficiencies. And it is essential that vitamin D deficiency, if patient is at risk, and if the patient is sarcopenic, it is fortified. It is part of consensus at the moment, not to blindly give vitamin D, but to fortify vitamin D. That is the case, and also use diet to fortify vitamin D as well. I hope Professor Lekavasam can also shed some light on that.
Yeah, actually, the role of vitamin D has been very much debated. Some studies have shown that the can you hear me?
Yes, sir. We can.
All right, okay. Yeah, some studies have shown that the vitamin D certainly improves the muscle functions and not the muscle bulk, but muscle functions. And but only thing, these studies have given a fairly high doses, in the sense something more than, let's say, 1,000 international units per day. And also studies have shown that the when given less than, let's say, about 400 international units per day, and that has a bit of, that has increased the risk of fracture and all. So now the recommendation is that, if you are thinking of giving vitamin D to improve muscle function of an old adult, I think you have to give something like 1,000 international units per day. But that's on the not a general recommendation that you can make. You can give drug and then assess the patient, and if there's improvement, certainly you can continue. But then it should not be taken as a kind of blanket treatment on older adults who say that, I have got a walking difficulty, and also only in selected people who get benefited by such treatment. There's a question in the chat saying that should we screen elderly people for vitamin D deficiency? Can I answer that, Sean?
Yes, sir.
Yeah, this vitamin D deficiency is a very much debated thing. If you screen, let's say, any given elderly population for vitamin D, and you'll find that nearly about 60 to 70% of those people will be vitamin D deficient, either vitamin D deficient or insufficient. Studies have shown all over, and particularly in Asian countries, that nearly 50% of the general population has got a vitamin D deficiency or vitamin insufficiency. When you come to the what I call selected population like elderly, and particularly what I call institutionalized elderly, vitamin D deficiency is very, very prevalent. So whether it is a condition that needs to be corrected is no one certain about it. I don't think anyone can give answer for that particular question. And it is very difficult to believe that 50% of the population suffer from a pathological condition that need to be treated. Um, so I would not recommend taking vitamin D in elderly people, and because that correction of that is will be very enormous difficult task. So I would not recommend quite generalized vitamin D screening for elderly people. Only selected people who have got a features of, let's say, vitamin D deficiency, like with proximal myopathy, difficult to get up from bath, and difficult to go downstairs, and people who are having falls, and there's a place for that, but not for general blanket vitamin D screening.
Now, I have a question to Professor Lekavasa. Is there a relationship between sarcopenia and osteopenia?
Right. Um, Recently, as Sean mentioned, that some entities emerge. For example, something called Sarcopenic Obesity. And when I went for one of these conferences recently, and there was an entity called um, Sarcopenic Osteoporosis Obesity or something like that. People tend to link up these things. But then we found that it is very, very well, but it is quite not necessary to categorize people in that manner. And what you are saying is to recognize what I call individual diseases. Now, for example, you can't say it's a diabetic hypertensive patient, and patient with diabetes tend to have hypertension. Patient with sarcopenia tend to have osteoporosis because they are common in old adults, so they tend to coexist. But apart from that, there isn't very much, and also you can think of that, let's say a low muscle mass would be linked to, let's say, low bone density. Uh, so they can coexist. So they coexist, is it because of those two are very strongly linked through their pathophysiological mechanisms, or is it because they are commoner, they are dealing with the age group where these two conditions are common? We don't know, but certainly these two conditions coexist. And if you got a patient with osteoporosis and coexist in sarcopenia, and then the risk of fall would be certainly very high, because that patient has got a higher tendency to fall. I hope I answered your question.
Another area that is essential is what we don't think about with regards to our patients, especially the frail elderlies, that we don't provide the space or the, the facilities to engage in some sort of mobilization or some sort of exercise itself, right? We prescribe exercise to people. I mean, when somebody comes to a clinic, let's say with diabetes or hypertension, obesity, etc. But we don't think about commencing exercise or any kind of physical therapy. We are a little bit reluctant to initiate that while a patient is in the hospital, especially to a patient who is bedbound. So there's a concept that has come up in the West, uh, gym in hospital or gym in wards. So there is facilitation or space given to the patients to engage in some sort of considerable or appropriate exercise. This has to be a part of our care as well. We have to seriously think of this. Any thoughts about that, sir?
Well, the physical activity has to be a part of the of life, really, and it's a gym in board, but it's had to be a gym you carry all right throughout your life, really, because you have to be physically active, and the benefits have been shown right throughout the life cycle. But how much you say that, I mean, with the general population, when you come to community, whether people are happy to engage in physical activities, and it's very difficult. I mean, clinicians should know that, very difficult to get to people to change their lifestyle. And studies have shown that, I mean, even among the people with impaired fasting glucose, you do physical activities and work very much like or better than metformin. But only thing that effect would not last long because they give up after the trial period. So keeping the people engaged in lifestyle modification and particular physical activities is enormous task for a physician. And unless you remind them every visit that your physical activity is so important. And so I totally agree that, I mean, if when you go to other countries like, let's say, China and Japan, you can see how elderly people are engaged in a Tai Chi and rhythmic physical activities of that nature, and really encouraging to see that. But then how we going to get that message to our people is I don't know, because there are cultural barriers and cultural norms and things like that. So that's my observation.
Mm, Any advice to vegetarians regarding sarcopenia, because now most elderly people are becoming vegetarians?
You Do you want me to answer that? Yep. It's a real issue actually that I address in all my old adults when patient comes, because for religious reason and various other reasons, what they do is actually when they get old and they drop their protein intake, which is not a good thing to happen actually, because we can see that when they come, their muscle mass perishes gradually, and this is not good for them. So I always encourage them to take adequate protein. And so the prescription, they say that I mean, you got high cholesterol and you got hypertension, this thing. So I said taking egg white is the option, because that would not disturb their cholesterol. So I generally encourage them to take a high protein diet, as uh, Shahan recommended that something in excess of 1 gram per, isn't it, per day, like I mean, uh, it is kilogram per day, is because it's very important for them to maintain their protein intake and not to switch into a kind of very high carb a small diet, like, because so generally what they do is just take small diet which are rich in carb but less in protein. um, so I don't think there's something wrong with what is called the vegetarian diet, and there is nothing wrong with that. But then if they cut down their protein intake in that, and that is the way it really matters.
With regards to a vegetarian diet, it's essential that we say that patients do increase the variety of vegetarian stuff that they would consume, because there is a place for complementary complementation of amino acids, because you see that in vegetarian food, vegetable or plant-based food, that not all the amino acids are readily found. So what is deficient in one, we can be obtained from adding another one. So, and also the quantity that the patient may need to consume with regards to vegetarian food, vegetable food, may be higher than the animal meats. So, and of course, if the patient is, if the person is not is able to take milk, or like what Professor said, eat eggs, then you have to fortify through that, but you need to be mindful of other things as well, like cholesterol, etc. So it's an important area. And with regards to us, there is an inertia in engaging our colleagues who are trained in nutrition sciences. So I believe most of the main hospitals in the country, at least of the provincial hospitals, there are MO nutritionists and nutrition doctors. So please don't underuse them, underutilize their help. Please refer your patients to them. May it be sarcopenia or any other disease.
um, Actually, somebody is asking a very important question, whether creatinine can be used as a biochemical marker for sarcopenia. And just very interesting concept, really, because one thing to be remembered that serum creatinine is not to be trusted entirely in people with old adults when you assessing renal function, because patient with a old adult, with the sarcopenia can have a normal serum creatinine, but with the abnormal renal function, because patient is not producing enough creatinine, and then serum creatinine would not go up, but blood urea become better index of renal function in old adults with sarcopenia that need to be remembered. I think that we remember it in geriatric care, that we always remember blood urea become better index than serum creatinine, particularly when the patient got sarcopenia, that we remember. But still, serum creatinine has not been validated as the index of sarcopenia, either muscle deterioration or the improvement. So that has not been validated yet.
Get another question. Is there an optimum level of leucine or optimum muscle protein synthesis?
So with regards to total protein in a sarcopenic or patient who is muscle depleted goes up to even 1 to 1.2 grams per kilogram per day. With regards to leucine, it's if you can remember, it comes to about 0.3 to 0.6 grams per kilogram per day. So it's not practical to measure the intake of leucine, etc., from the normal diets that we take. But if you are really interested, there are food atlases that have been validated for Sri Lanka. I think Professor Ranil Jayawardene has recently published this for Sri Lanka food atlas, so you can get inference from that. Of course, if you are using pre-packed food, nowadays you get the energy as well as the protein quantity per mass depicted in the label, so you can get an idea of that. But you don't have to go by a general calculation. But if you can take the message to your patient that you need to increase the protein intake compared to the calories. That's the important thing, to reduce the calories, especially in a patient who has sarcopenic obesity, and to increase the lean muscle mass. So if you can remember that slide that I put in, one may get fooled by just calculating the BMI. So if some person one person may have, let's say, a BMI of 23, but the fat content that the patient may be having will be higher, and the lean muscle mass will be less. Whereas another patient with the same BMI may be having a higher lean mass, but the fat content is less. So who is healthier is the question. And this comes into play when the BMI goes up, let's say more than 24 or 25, according to our cutoffs. So you see that you might be fooled with the total fat amount.
Right.
Yeah. Yes. Yeah, so that's a very good question. Whey proteins, as I said, the content of protein or the leucine is very high, but it's very expensive. And mind you, they come in large bottles, like almost the size of a gunny sack of rice or whatever. So the alternative, as I said, was to use this in our culture. There was a thing called moru that was used when the milk is curdled, and there is the remnant after the fat has been extracted. It's used. I think it's very much used, not so much in the Sinhala cultural background, but especially in the Tamil-speaking Tamil ethnicity. It's a part of their diet. So moru, or more, as you say, that's the way, the extract out of after the protein case, the casein and everything has been taken off. That is the best option. Because I'm not sure whether it is available in the market, let's say in the supermarket or so. Maybe in rural areas, it may be available in local farms.
I have one more question to Dr. Shehan. You said that metformin is repurposing as a useful agent for sarcopenia. So would you advocate metformin use in pre-diabetic patients, elderly pre-diabetic patients, for prevention, preserving muscle mass?
Very debated question. I think many clinicians prescribe metformin to reduce weight and to think about pre-diabetics. But then with terms of sarcopenia, there is no consensus still. As I mentioned, all the pharmacological agents that we spoke of, they are still research level, and there's no class A or level 1 evidence as of yet. So there is no drug or not. I won't advocate metformin, but maybe in a couple of years' time, when, as it says, medicine, what is practiced now, 50% will be outdated when we retire, when I retire.
Thank you, Shehan.
Can I just say something? We feel that bit, let's say, anxious about the unavailability of medications to tackle sarcopenia right now. The situation prevailed in osteoporosis about, let's say, 20 years ago. We only just had vitamin D, and we were treating patients with osteoporosis with something like anabolic steroid, which is not used at all now. And so options are very, very limited, and almost we had non-existent that pharmacological agent when we treat osteoporosis. But once the definition was given and the people started, taking that to clinical arena, and then the pharmaceutical industry saw the opportunity, and they expanded their research for, R&D, searching for drugs for osteoporosis. And since then, you can find that so many things came to the market. So now we have got a fairly a wide range of drugs available to treat osteoporosis. So I'm sure it's going to happen to sarcopenia as well in time to come. And as long as the clinicians are willing to take that on board and then consider in the patient evaluation, I'm sure the pharmaceutical industry will fall behind it, and will expand the R&D and search for drugs to treat sarcopenia. That would happen. Right now, we have very little to offer.
Any questions?
Shan, I'm really impressed that at one point there were 135 people in the participant list, and this reminded me about 10 years ago. We were doing a elderly care parallel session, and on the other side there was a session on cardiology, and it was difficult for me to, as a resource person, retain 10 people in the audience, and because it was split between like a 98%, 2%, like between the two congresses. So it was difficult task to keep even 10 people in the elderly care workshop. But I'm really impressed that 135 people have joined in online. So in addition to people who are in the audience, so I'm really impressed with that number. So thank you.
Thank you all for joining us in this session, this pre-congress workshop. We will now take a break. We will assemble again at 10:45 a.m. We hope you will have a virtual cup of coffee or tea. Sorry about not being able to give you the normal meals as what you give for an academic session.
Before we move to tea, let me give a token of appreciation to Dr. Shehan Silva on behalf of the Ceylon College of Physicians.
We will assemble at 10:45 again. Thank you.
Thank you.
we start our second segment of the workshop on sarcopenia and frailty. Our second segment is themed on frailty, and there will be 3 lectures, 2 on frailty and 1 on falls, which is a consequence, important consequence of frailty. And I welcome Dr. Achala Balasuriya again as the moderator of this session. Thank you.
Welcome back for the second half of the session. May I now invite the first speaker for this session, Dr. Santa Ganewate. She is a consultant physician at Base Hospital, Tengol, and she is a past Vice President of the Sri Lankan Association of Geriatric Medicine. And Dr. Lasantha will be talking to us on definition and detection of frailty.
Good morning. Thank you very much, Chair Madam, for your kind words of introduction. My presentation is on definition and detection of frailty. This is the content of my presentation, the definition of frailty, the prevalence of it, factors involved in the development of frailty, the models of frailty, and how do you detect frailty, and some conclusions. The frailty is the most problematic expression of population aging. So it's the state of vulnerability to poor resolution of homeostasis leading to physiological decompensation, which leads to dramatic decline of physical as well as mental well-being of elderly population following a very even minute stress event, like a very minute minor insult like a simple urinary tract infection. So you can see very dramatic decline of physical and mental well-being of them if they have the frailty. So this is the definition given by the British Geriatric Society. It's a distinctive health state related to the aging process in which multiple body systems gradually lose their inbuilt reserve. So this graph simply demonstrates what is the consequence of frailty comparing to non-frail, robust individual. So the y-axis demonstrates the functional abilities, x-axis is the time. The green line shows the non-frail, the robust individual, how they face a minor insult. So you can see the baseline of their functional abilities is very high. So when there is a minor stress event, there is a little decline of their abilities, but they recover soon to the baseline which they were before the insult. But the red line shows the frail elderly individual where their baseline is very low. They are very barely at the level of independent, but it's the very close to the boundary of independent. And with a minor stress event, there will be a dramatic and drastic decline of their functional abilities, and they recover slowly and they come to a level which is not the baseline they were before the insult. And you can understand if this sort of insults are happening recurrently, their baseline functional level will go down to the dependent level. So the outcomes of frailty, ladies and gentlemen, will be dependent to independent, mobile to immobile, postural stability to falling, and lucid to delirious. Not only that, frequent hospitalization, institutionalization, and even death. So these are the outcomes of frailty. You can understand this is the most problematic expression of population aging. This is the prevalence of frailty. So the frailty is obvious, is increased with the advancement of the age, and the frailty is commoner among females compared to males. And so also it is in a lot of epidemiological studies have shown that age more than 65 years, they have 10% of frailty among those population. If the age is more than 85 years, then the frailty will be more prevalent. It is 25 to 50% of them will have frailty. So We all know the aging is a process where there will be accumulation of molecular and cellular damage of decline in multiple body systems, and which is regulated by the repair and maintenance mechanisms under very strict regulation. So we all know our body systems have enough and greater redundancy, which means that we have physiological reserve. For an example, brain has enough neurons than required, and the muscles have more myocytes than required. So when we are aging, that we deplete this physiological reserve, and if the many systems are depleting this reserve, they will go into frailty. Even we are talking about many systems, the main systems interrelated in frailty are brain, endocrine, immune, and musculoskeletal system. So this is the main changes happening in brain when it comes to frailty. The structural and physiological changes in neurons with the high metabolic demand, where the highest metabolic demand is happening, the hippocampal pyramidal neurons. So we all know it is directly related to the cognitive impairment and leading to Alzheimer's disease. And the microglial cells are the brain immune cells, so brain macrophages. With the structural and physiological changes are happening in these microglial cells, they are primed, and if there is these primed microglial cells lead into delirium when there is a trauma to the brain, or if there is a systemic or local inflammatory response. So that is they are in the brain. Then the next system is the endocrine system. Endocrine system shows a lot of changes when we are aging, but mainly the decline in growth hormone and insulin-like growth factor 1. We all know the insulin-like growth factor 1 is the major anabolic hormone in the body, where the muscle synthesis and hypertrophy is being maintained. And the decline in estradiol and testosterone levels, and decline in dehydroepiandrosterone level, and eventually increase in the cortisol level. So when the people are aging, they are running with high cortisol levels with decline of these anabolic hormones. And eventually, the immune system also getting a lot of changes with aging. What will happen? We all know the elderly people run in a low-grade immune response. The low-grade immune response, if there is a stimuli, there will be the prolonged immune response. Even we remove the initial response, this inflammatory response will be going on. So they are running with elevated levels of interleukin-6, C-reactive protein, tumor necrosis factor alpha, and a potent pro-inflammatory mediator, CXC, chemokine ligand 10. So these are the common elevated inflammatory markers in elderly people contributing to frailty. Then the musculoskeletal system, sarcopenia was extensively explained during previous 2 lectures, and sarcopenia is the loss of muscle mass, power, and the strength. And we all know this muscle synthesis as well as hypertrophy, and the protein loss is maintained by the very finer balance of immune system as well as the endocrine system and physical activity and nutrition of the individual. This finer balance finer balance is lost because of the changes happening in the endocrine as well as the immune system, especially interleukin-6 and tumor necrosis factor alpha activate the muscle breakdown, and this is leading to sarcopenia. Sarcopenia is the key component of the frailty. This schematic demonstration will show that immune endocrine axis in frailty, the endocrine changes I have explained, and the increased level of inflammatory markers leading to anemia, sarcopenia, and hemopoietic changes and changes in clotting mechanism, ultimately leading to frailty and adverse health outcomes in aged population. Having said that, the most researchers who investigated the biological and physiological reserves which are being depleted during the process of aging, which is leading to frailty. But we all know the aging is it's a very complex process where the genetic as well as the environmental factors are interrelated. The genetic and environmental factors are interrelated, and the environmental factors are the wider components of determination of the health and aging. What is the environmental? What are the environmental factors? Mainly the people where they born, where they live, where they work, where they grow, and where they, the socio-economic background and societal norms. Not only that, the development agenda of this particular community, all these are environmental factors which is contributing to aging and the frailty. So in this schematic presentation, you can understand the biological and physiological component is one of the 5 components of contributors for the frailty. These are the wider determinants of frailty. For an example, the individual factors. If somebody is smoking, he will become frail. He will be frailer compared to a non-smoking individual. If somebody is doing good physical activities, he's doing good physical activities, he does not have frailty when he's aging compared to a person who is having a sedentary lifestyle. And the socio-economic and living conditions also. So if somebody is living in a good socio-economic background, so good socio-economic country or the community, they will have less frailty compared to people who are living in poor socio-economic background. When we are formulating a sort of a good geriatric network, good geriatric care community, we have to consider these factors as well. And the social and community networks. There are several components, but I would like to tell that, for an example, if somebody is living in a city, if an elderly person who is living in a city which is very elderly friendly and which has good city planning, that the elderly people who are living in this community will not be reluctant to go out and get their things fulfilled, and then the time taken to become frailty will be higher because they will have enough facilities to live a good life. But if somebody is living in a city where the city planning is not good, very lot of congestion and traffic and things, the elderly people are reluctant to go out. They are mostly homebound, and they will become frailer compared to people who are living in a good city planning area. That is a very simple explanation. And the next in the resilience. Resilience is inversely related to the frailty. If some resilience is the capability to bounce back, the ability to adapt or negotiate the insult or the stress events. They will easily bounce back to their baseline. We, as clinicians, we should understand the components of the resilience, and we should be able to strengthen those areas to make sure that the frailty is being addressed. So, the models of frailty. These are the 2 models. There should be reliable models to identify and predict frailty in a community. There are 2 models, the phenotype model as well as cumulative deficit model. The phenotype model was described by a well-known researcher, the Fred and his colleagues, in the cardiovascular research study, cardiovascular health study, where they have examined more than 5,000 individuals, males and females, and they have found there are 5 characteristics common 5 characteristics in the phenotype model. Those are unintentional weight loss, reduced muscle strength, reduced gait speed, self-reported exhaustion, and low energy expenditure. That you can measure these variables and you can predict the frailty. So the frailty, if there are 3 or more characteristics or variables, we call them as having frailty, but 1 to 2 will be pre-frail. If somebody does not have this even a single criteria, so then we call them as robust old individuals. So by looking at this phenotype model, you will understand in these 5 variables, there is no cognitive component. Cognitive component was not addressed in the phenotype model. Not only that, the disabilities of the individual also was not addressed in the phenotype model. And also the minus point of this phenotype model is that you can grade the frailty, and there is no better discriminative value of discrimination in between severe and moderate frail people. You can discriminate by using the phenotype model. And this is the prevalence of phenotype model: weight loss, exhaustion, physical activity, walk time, and grip strength. Grip strength is a surrogate marker of muscle mass and strength. So you can see the grip strength is the highly prevalent variable of out of 5 phenotype models. So as I said, therefore the sarcopenia is the key component of the frailty. Then the second model is the cumulative deficit model, where it was described by the well-known researcher, Canadian researcher Rockwood. The Canadian study of health and aging, the frailty index was formulated by Rockwood, where they have found 92 baseline parameters. In that cumulative deficit model, they have addressed many items in the health: the symptoms, signs, abnormal laboratory values, disease status, disability, cognitive functions, psychological component, and social factors. All these things got together to formulate the 92 variables in the cumulative deficit model. So in the initial stage, research, that there are 92 deficits. However, the different researchers in different populations, they have studied and they make it more user-friendly manner, nearly 30 to 34. This is an example, 30 to 35 variables in the cumulative deficit model. By using this cumulative deficit model, definitely you can calculate the frailty index. Frailty index is the number of different deficits in the individual divided by total number of deficits measured. So you can have the frailty index. The frailty index is exponentially related to the mortality of the individual. If somebody is having higher frailty index, their mortality will be high. So you can predict. Not only that, you can grade the frailty, and there you can understand there is a better discrimination. You can do better discrimination between groups of frailty also by using the frailty index. So the frailty, comorbidity, and disability. We see there are a lot of similarities in between these three components, these three areas: the frailty, comorbidity, and disability. The symptoms and signs are being shared. The studies, most of the epidemiological studies, they have found that frailty and comorbidity go together in nearly 50% of the population, elderly population. Frailty and disability will be nearly 6%. Frailty and comorbidity and disability together will be 22%. The most important, the frailty only people, there will be 26%. We have to identify in our geriatric population this frailty only people. These are the cohort, these are the population we can manage very easily. Their frailty can be reversed very easier way. So the frailty only, it's a component is important to identify. So having said that, having discussed all these frailty models and all, we'll see how we are going to detect the frailty. So the detection of frailty is done to improve the outcomes and avoid unnecessary harm. By detecting the frailty, we can balance, we can plan the management plan of the patient according to the level of frailty. And we do frailty assessment and detection of frailty on all encounters with health and social care professionals. And frailty is not a static. It can be worsened or it can be reversed. So we have to do periodic frailty assessment in our patients. It's not, and also we should understand as clinicians who are dealing with a lot of elderly people, it is not an inevitable part of aging. So where we do the frailty assessment and frailty detection. Usually we do it in the routine outpatient appointments and also social service assessment. When we work in United Kingdom, we see the social service department workers, they come and assess the patient's frailty before they plan the care package. The level of frailty is very important aspect to plan the care package, and the review by the community care team. Then even though the hospital, when we are discharging the elderly person to the community care team also do their own individual frailty assessment, and the primary care review of older people like your GP and home carers in the community. Not only that, ambulance crew, the ambulance crew who goes to take the patient to the emergency department, they do on-site frailty assessment, and then they hand over the patient to us. When we are in the emergency department, they give the frailty index of the patient. They have those pro forma with them, and they do the on-site frailty assessment. And how do you do the frailty detection? Definitely, if somebody is presenting, if an elderly person presenting with frailty syndromes, we have to do the frailty assessment. This is traditionally called as geriatric giants: falls, immobility, delirium, incontinence, and susceptibility to side effects. On all these 5 areas, if your patient presents with one of those geriatric syndromes, then you have to assess the frailty and you have to grade the frailty and you have to plan accordingly. You have to plan your management accordingly. And then that is in the acute and emergency ward. Then you do the routine assessment in your outpatient clinic. There are several ways of assessing the frailty to detect the frailty. The one is the Plasma 7 questionnaire, where you ask very simple 7 questions, which is described in this slide: the age, the gender, the available facilities, and the available help, and their walk-in. All these simple things we ask them, and we give 1 mark to a yes answer. If somebody is having 3 or more than yes answers, then it is identified as frailty. And then you do the walk-in speed of the patient. You ask the patient to walk 4 meters. If they are using a walk-in aid, they can use it. And if they can walk 4 meters within 5 seconds, so it is less likely that patient is having frailty. And the other one is the timed up and go test. You ask your patient to stand up from the standard armchair and walk 3 meters, turn and walk back to the chair and sit. That if that process takes only 10 seconds or less than 10, that patient's frailty is less likely. And also you can ask your patient to self-report their health. They rate their own health, asking 0 to 10, where you are going to rate your health from 0 to 10. If it is 6 or more than 6, that is also one indicator that your patient is in frailty cohort. And your GP's assessment. GP is the frequent assessor of the elderly individual, geriatric person. So then the GP assessment is also one of the good ways of assessing frailty. And if your patient is having multiple medication, if they take multiple medication, that also we should note that is also an indicator of frailty of the patient. And the Groningen Frailty Indicator Questionnaire, where they have 15 components of 4 domains like physical, mental, psychological, and social. Physical, cognitive, psychological, and social components, 15 questions, and you give a score. And if the score is 4 or more, then that is also taken as frailty. These lot of scales and tools are there. These are the commonly used one. Then the Edmonton Frail Scale, we all aware, this is one of the best tool we use to assess pre-operative assessment of an elderly patient before they go into a surgery. Edmonton Frailty Scale, that is, there are 9 components. We assess their cognition, general health status, functional independence, and their available social support, medication use, the nutrition also get addressed, and mood, continence, functional performance, and you give marks and you grade the frailty accordingly, and you plan the surgery and the post-surgical care accordingly. So you give a score. If somebody is scoring 12 to 17, they are severely frail. We have to be careful before we operate the patient. And if 0 to 5, that is not frail. So we should give this, information to the surgeon. And this is the clinical frailty scale, where we commonly use in our clinics. From 1 to 9, very fit to terminally ill. There is a grading system from 1 to 9. The pictorial demonstration show that the level of frailty of the individual, and you do clinical frail scale and frailty scale, and you assess the frailty and you detect the frailty. It's a very simple and not time consuming. This is mainly we use in our clinics as well as the medical wards to assess frailty in elderly individuals. And this is the comparison of diagnostic test accuracy of these instruments. So you can see the gait speed walk in 4 meters within 10 seconds has 99% sensitivity, but specificity is low. The Prisma 7 questionnaire carries good sensitivity and specificity, the reasonable sensitivity and specificity. So the British Geriatric Society recommends, if you do gait speed, timed up and go test and Prisma 7 questionnaire together, the predicting frailty of doing 3 tests together will be very high. So this is the good comparison of sensitivity and specificity of parameters, the instruments that we discussed so far. So finally, there are some studies which are going on to assess and find instrument to detect frailty. The grip strength is a useful single marker of frailty. Yes, the grip strength may prove a more useful single marker of frailty for older people of similar age than chronological age alone. That was done recently, and it's a surrogate marker of sarcopenia, which is the key component of the frailty. And the development and validation of an electronic frailty index using routine primary care electronic health record data, which was done in United Kingdom by Andrew Clegg and group, and they have found that study to develop and validate an electronic frailty index using routine available primary care electronic health record was useful, and we have to think when we are for our community, when we are formulating frailty index, to use these available resources. So finally, I would like to do this conclusion after my presentation. This frailty is the most problematic expression of aging. There is loss of biological reserves across multiple body systems in frail people. The minor stress event triggers disproportionate decline in the health status of the individual. Then it needs to understand wider determinants of development of frailty. Landmark studies have developed valid models and which we use in most of the studies. And there are many tools to detect and grade the frailty. So, thank you very much.
Thank you, Dr. Lasanta, for that interesting lecture. We will take the questions after all the 3 presentations. The next presentation is on management and prevention of frailty. This presentation is be done by Dr. Dilha Samaravira, who is a past president of the Sri Lankan Association of Geriatric Medicine, and he's a consultant physician attached to Colombo South Teaching Hospital. Over to you, Dilha.
Very good morning to you. Thank you, Achala, my colleague and the founder secretary who worked with me when we initiated the Sri Lankan Association of Geriatric Medicine. And also I would like to thank the president of the CCP and the council, the president, Dr. Ananda Vijayavikrama, as well as the president of the Sri Lankan Association, Sri Lankan Association of Geriatric Medicine, Professor Atle Kamasam, and the council for giving me the opportunity to do this lecture. So today, the topic is prevention and management of frailty. Okay, so we'll start with these pictures that you see. So on your left side, you see a gentleman who is running, and on your right side is a gentleman who is being helped with an assistant. Now, when you see these 2 pictures, I used to ask this question from the audience when I do the lecture, who do you think is older? And I get different responses from the audience. And some people say the gentleman in the blue shirt is older. But in fact, Mr. Singh, who actually lived up to 100 years, on your left is not frail. So my lecture will be how he prevented becoming frail. So, I mean, if all people lived like Mr. Singh, the geriatricians will run out of their jobs. So we need to find out what are the reasons for Mr. Singh to be like this at 100 years, a higher chronological age and lower biological age. So the factors, as Lasantha mentioned, there are many factors ranging from exercise, diet, lifestyle, genetics, then health habits like smoking, alcohol, and other socioeconomic reasons. So all of these are important in the prevention of frailty. At the same time, we need to find out what we can do for the gentleman in the blue shirt. So that's the other aspect of my lecture. That is how to manage the frail older person, which is actually comprehensive geriatric assessment. So, as you saw in the previous lectures, you would have noticed that there is a certain overlap between these areas. So when I talk about prevention of frailty, I probably will be talking on some aspects of sarcopenia. As you saw in the previous lecture, the phenotype classification of frailty mostly involves the concept of sarcopenia. But of course, frailty is not only that. It's a physical, mental, social, and even spiritual aspects. And the cognitive frailty is another aspect that we talk about most of the time today. So it is important to talk about the life course approach. So we all go through these 3 stages in life. First, it is a childhood to adolescence, and where there's an identity crisis of becoming an adult, and then the midlife, and then you come to another identity crisis where you are going to retire and then become the older person. So these 3 stages are conventionally defined as period of training, period of social and family responsibility and duty, and self-responsibility and freedom during the old age, stage 3. But what we advocate as active, healthy aging is about lifelong learning, lifelong working, and lifelong security. This is the concept that we need to foster for all of us to live with a better quality of life in our old age. I thought this is a good statement that I should highlight in my lecture. What people want differs among individuals. We all have different desires and changes over the life course, having a role, an identity, relationships, the possibility of enjoyment, autonomy, being independent and able to make own decisions, security, and the potential for personal growth are some of the things that older people identify as important for them. So this should be the concept. In different stages of life, we have different roles to play, but we all need to enjoy, and we all need to be part of the society, participation in the society. So with this intention, the World Health Organization has declared a decade of action for healthy aging, that is from this year, 2020 to 2030. A multi-sectoral approach moving from a disease focus to the perspective of functional ability that enables older people to live according to their values and priority. This is the concept of the decade of action for healthy aging. What we need to realize is that to have a better quality of life, to prevent frailty, it is not just the health aspects. So there are many aspects. The living environment, the politics, the policy statements, all of these. So that it's a wider area. The private, public, all these sectors need to incorporate. That is why we talk about a multi-sectoral approach. Healthy aging is defined by the World Health Organization as the process of developing and maintaining the functional ability that enables well-being in old age. So functional ability is the most important aspect when we are aging. So Shehan said that I will describe more about this, the life course approach in sarcopenia. So you could see that in this graph, the early life peak in muscle strength is important to maintain muscle mass during the midlife, and also to have a better strength and less sarcopenia when people grow old. So it's important to have a good nutrition, physical exercise when you are young and reach a maximum peak in muscle strength. And it is important to maintain that muscle in the middle age. And also towards the latter stage, you need to find ways to minimize loss in old age. So those are the ways that Shahan described. Resistance exercises, aerobic exercises, good protein in the diet, all of these matter for us to have minimize loss in old age. So this is from the guidelines of sarcopenia from the European consensus and definition. Okay, and this is the life course approach for frailty. So it's now you can see a red line. In this red line, it's normal aging. So we, all of us, we wouldn't become frail if we live a life where we practice healthy food habits, exercise, diet, and all of that. But if you eventually live to a very old age, you may become frail. But then you see that dotted line, the blue line, where you are experiencing accelerated aging. Now, this is due to diseases, multimorbidity, and then poor diet, poor health habits, poor exercise. All of these contribute to the accelerated aging. And you could see that in the middle, if you look at it, there's a window that is called frailty time window. This is the period that you need to be careful. If you do not manage these frail people, if you do not detect them at this stage, they might end up in disability, which we don't want to see. So we need to prevent disability and prevent frailty as well. Therefore, we need to address these older people very early. So furthermore, on prevention of sarcopenia, the life course approach, it is important to realize that low birth weight contributes to sarcopenia in later life. Small size at birth is linked to lower grip strength at age 60 or 70 years. Prepubertal and pubertal growth all matter, and these are important in reducing sarcopenia towards the latter half of life. So diseases, risk factors, personal conditions, lifestyle, all are important in the life course approach. The risk factors that we could talk about are old age, low socioeconomic status, low physical activity, poor diet. And there's also evidence on alcohol consumption and cigarette smoking. All of these influence frailty as well as sarcopenia. So I told you that socioeconomic factors are also important. Studies have also shown that the level of education, income, marital status. One may think that having a wife would shorten your lifespan due to the problems caused by your wife, but it is actually not so, because having a partner, having ability to share your experience with a partner will enable you to live independently longer, even though your independence with your wife may be limited when you live with her. So frailty prevention calls for a multifaceted approach. So addressing all these environmental factors and the social economic factors. So I would like to talk about the World Health Organization concept on integrated care of older persons. Now, the World Health Organization defines intrinsic capacity as a combination of individuals' physical and mental capacity. There are 6 domains that are assessed. Now, this is not assessment of frailty, but assessment of the elderly persons. We think that there are 6 domains that should be addressed. I'll just briefly tell you. They are psychological, that is mainly assessment of depression. Cognition, that's assessment for screening for dementia. Mobility, the chair rise test that we talked about in assessment of sarcopenia is used for this. And the vitality, that's about nutrition. And the sensory, there are 2 components. That's why we say 6 components, that is vision and hearing. So what is functional ability? According to the World Health Organization, combination and interaction of intrinsic capacity with the environment a person inhabits is the functional ability. Now, just imagine there's a person who is having difficulty in walking due to sarcopenia, due to weak bones, due to poor nutrition. Now, if we give this patient a good rehabilitation process, provide good nutrition, provide good exercises, we increase the intrinsic capacity. And if I'm able to provide walking aids and then facilities in the environment like ramps, then he would have a better functional ability. So this is the concept. So for this, not only the health sector, but multi-sectoral approach is important. So furthermore, on the ICOP approach, when we talk about intrinsic capacity, there are high and stable, declining, and significant loss. There are three groups that we talk about. So high and stable, people with significant loss of intrinsic capacity, and the declining. So the ICOP approach is for the people who have declining intrinsic capacity and who have significant loss. But of course, high and stable people should also be encouraged to maintain their muscle mass, their activity, and prevent from this decline that occurs. So just to briefly touch on the concepts, ICOP care, maximize intrinsic capacity and functional ability, person-centered assessment and personalized care plans, community level and home-based interventions, multidisciplinary care teams, support for self-management, support caregivers, ensure referral and follow-up. All of this would prevent frailty if properly addressed. And we are also part of this, and we also have taken part in these meetings representing the Ministry of Health and the Sri Lankan Association of Geriatric Medicine. Now, we all know the intrinsic capacity declines when we age. And the functional ability also decreases when we age. And we have three groups, which I mentioned you. And then what we need to do, all efforts should be to increase the intrinsic capacity of an individual. And also improve the environment and see that the functional ability is improved. A public health framework for healthy aging has been designed. So the intrinsic capacity, functional ability, then there are three groups. The health services should aim initially in early stages of life to prevent chronic conditions. You know, the non-communicable diseases prevention is very important because that will prevent multimorbidity. So in early stages, prevention of these diseases. And later, when people develop diseases and decline in capacity, do whatever you can to reverse or slow declines in capacity. And then as a person becomes frail, then we need to manage advanced chronic conditions, provide them long-term care facilities. So the long-term care facilities is another concept that is very important. So as we age, support capacity-enhancing behaviors when people are able. But when people are so frail that they are unable and then when they're disabled, then we need to talk about ensuring a dignified later life. That includes palliative care. And talking about the environment, promote capacity-enhancing behaviors in the environment. And when people become frail, we need to realize that we need to design buildings and provide elderly-friendly facilities, remove barriers to participants, compensate for loss of capacity. So this is the public health framework for healthy aging. With all these efforts, our intention is to ultimately increase the intrinsic capacity and the functional ability. So the management of frailty, the gold standard for care of people with frailty is comprehensive geriatric assessment. A Cochrane review showed that those who underwent comprehensive geriatric assessment on a ward, that is in a medical ward, had a 30% higher chance of being alive and being in their own homes at 6 months. This equates to a number needed to treat of 13, which is actually a great number if you compare other studies which have used medicines for cardiovascular and other diseases. So it is evidence-based. Frail elderly people receiving inpatient comprehensive geriatric assessment on specialist elderly care wards are more likely to return home, are less likely to have cognitive or functional decline, and have lower in-hospital mortality rates than do those who are admitted to general medical ward setting. And this is why we are demanding the Ministry of Health to develop elderly care wards, because we believe that providing comprehensive geriatric care and identifying frailty would make a big difference. So comprehensive geriatric assessment, it's a multidimensional, multi-professional, interdisciplinary diagnostic process. So multidimensional because physical, mental, social, spiritual, all these aspects are addressed. Multi-professional because we need teamwork, geriatricians, physicians, medical officers, nurses, physiotherapists, occupational therapists, social service officers, dietitians, pharmacologists, psychiatrists, so many people we need. And it is an interdisciplinary diagnostic process where a team works, a limited number of people, mainly the nurse, the doctor, the physiotherapist, social service officer, and the occupational therapist. They work together. And it's about this holistic care, taking care of environmental, mental health, medical, social circumstances, and the center of it is the functional capacity. So in practice, you know about the proactive care of older people undergoing surgery. In these routine surgeries, frailty was detected and they applied comprehensive geriatric assessment. And the result was that people who underwent comprehensive geriatric assessment had less delirium, pneumonia, the ones in red, wound infection, uncontrolled pain, pressure sores, delayed discharge, length of stay was reduced, and the delayed discharge was less. So it's definitely evidence-based. The British Geriatric Society, BGS, Fit for Frailty document highlights the recommendations in comprehensive geriatric assessment. Comprehensive geriatric assessment is totally another lecture. So I will not go into detail, but just to highlight that, as I mentioned, it's a holistic review of medical functional, psychology, and social needs. And you need to have a liaison with old age psychiatry, and also stop-start criteria, when to start certain medicines, when to stop. The polypharmacy, of course, leads to frailty, as mentioned by La Santa. And we have our own stop-start criteria. We have done a publication, I was also part of it. And we have a stop-start criteria list for our own country. So we need to have personalized care pathways and end-of-life care pathways and so on. So managing physical features of frailty. Now, most of these factors we have gone through. Benefits of exercise we have discussed. It improves mobility and functional ability, strength and balance training, resistance exercise. All of these are evidence-based. I just mentioned to you about this study for the benefit of the trainees. LIFE, which is Lifestyle Interventions and Independence Wilders, phase 3 multi-center randomized control trial, in which they compared the effects of physical activity program with a successful aging educational program in more than 1,600 functionally impaired older persons. So in this, they found that the physical activity intervention reduced the risk of developing mobility disability by 18% relative to the control group. So the largest effect was observed in the more frail, the severely frail people. And also they found in this study, in other sub-studies, that positive effects of exercise also improved cognitive capacity. So, and then this is about a scoping review of several studies where they chose 14 studies. And in this, they compared several studies, which include these physical intervention, physical activity compared to control, physical activity combined with nutrition, home modification, then rehabilitation, that's about physical therapy plus exercise plus home modifications and comprehensive geriatric assessment. So, and also they tried these nutritional interventions like the multifiber formula, vitamins B6, B12, D, and calcium, all of these. The conclusions of these studies, most of these studies, actually 9 of the 14 studies were effective in preventing or reducing frailty. What they found is that exercise, all types, and all combinations of exercise with any other proved to be effective. But comprehensive geriatric assessment in the community dwelling elders was not that effective. It has been effective in the medical wards, but not in the community. But having said that, I have come across some studies which have shown reduced hospital admissions and better quality of life by the comprehensive geriatric assessment in the community as well. And prehabilitation, where they combine these home visits and exercises, also was successful. Then pharmacological interventions, this is just to mention, because we have discussed them in detail in the Sarcopenia lectures. And vitamin D we discussed very extensively. And then there are other things like the essential amino acids, leucine, omega-3. And interesting for us, because we are people who drink a lot of tea, large-term tea consumption improved mental health. This is one study, actually. This is not conclusive, but these are just to give you some insight on some of these nutritional factors. And of course, the Mediterranean diet improved the physical performance in using the short physical performance battery and hand grip strength. And olive oil is part of Mediterranean diet. So proven, has shown to lower levels of these inflammatory cytokines, TNF-alpha and interleukin-6. This is by interest. Okay, so talking about vitamins, vitamin E is much talked about. But what I found in analysis of most studies on nutrition, that frailty is associated with lots of these vitamin deficiencies. But giving vitamins and proving that frailty is reversed has not been proven that much in most of the studies. It's actually not proven in these studies. So if you take vitamin E, you can see the association. It is more associated, vitamin E deficiency is more associated with intermediate frail and very much more with frail. And if you take the other vitamins, B6, B12, folate, all of these, there is a higher association in this study. So the frail is in the light color. So you can see the frail people have more vitamin deficiency if you take a single vitamin deficiency. And then if you take zero vitamin deficiency, again, the robust people have zero. So again, it's less in the frail. And then if you take one, again, vitamin deficiency, again, frailty is associated. And if you take two or more multiple vitamin deficiency, again, frail people or elderly people have more multiple vitamin deficiencies. So the association has been shown. Then also in the future, as Shan mentioned, the sarcopenia and physical frailty in older people, multi-component treatment strategies. SPRINT study has been concluded, and we are expecting results from this study. It's a randomized controlled trial aimed at comparing the efficacy of multi-component intervention, which actually that is the way forward in preventing and managing frailty, multi-component intervention, based on long-term structured physical activity, nutritional counseling, dietary intervention, information and communication technology intervention, versus a healthy aging lifestyle education program designed to prevent mobility disability in 1,500 and older persons with physical frailty and sarcopenia who will be followed up for up to 30, who have been followed up to 36 months. We are waiting the results. So as we are talking about COVID-19, so this is actually sent to me. This is a pro forma which is used in UK by our good friend, Dr. Kitsri, who used to work with us in the Sri Lankan Association of Geriatric Medicine. So because when we want to develop algorithms for our elderly people. So we believe that at the doorstep, when a person arrives to the hospital, we need to identify the frailty status. So we need to have a way of identifying, use a frailty scale, a simple tool, and then identify who are more frail and who are less frail. And then identify people who have suspicion of COVID and who have COVID positive, and then have an algorithm to manage this. Here we need to decide initially whether a person is needing, should be taken for critical care as an initial management, or whether we should not move the person to a critical care side. And if the person is not going for critical care due to reasons identified in the frailty assessment, then we need to treat the person. If the person improves, yes, then we can treat and discharge the patient. And if the person doesn't improve, again, we need to have a plan for palliative or end-of-life care. And where this care could be delivered, it's certainly not in a corner of the isolation ward where you can't see with all these glass cubicles and all. So we need to move them into a side room, a different place. And then we also need to have a communication system, and we need to accommodate the bystanders in certain people. And actually, as the Sri Lankan Association of Geriatric Medicine, we have taken the responsibility of developing this the guidelines on management of older persons in this COVID-19 crisis. And we have actually made one, but I'm not showing it to you because it's not finalized. So we think that actually one of the things that we thought is, when a COVID positive older person who is frail, who is bedbound, maybe who cannot move, is admitted, what to do? Whether we could use the asymptomatic COVID positive people as volunteers to go and care for them rather than the health staff moving in and out. So these are areas to think about in management of the frail older persons with this COVID-19 crisis. So thought for you. So think about what we can do and come out with a plan for our older persons. So in summary, prevention of frailty in older persons will lead to an increase in quality of life and will enable a longer period of independent life. Healthy aging across life course should be encouraged by integrated care, shifting away from single disease approach. That's very important. Improving the intrinsic capacity and the environment of the older person will result in a better functional ability. That's the ICOPE strategy in a nutshell. And if you want to read more about ICOPE, Integrated Care of Older Persons, and if you want to use the tool to assess elderly people, just Google it, ICOPE, WHO, and you will receive the tools as well as the handbook. Finally, comprehensive geriatric assessment, a multi-dimensional assessment that includes medical, physical, cognitive, social, and spiritual components, is the gold standard tool for the management of frailty. So thank you very much.
Thank you, Dr. Dilha. Thank you for your presentation on prevention of frailty and keeping to time. We will move on to the last presentation for this session. The last presentation is on evaluation and prevention of falls, presented by Dr. Barana Millavithana, consultant physician attached to Provincial Teaching Hospital, Kurunegala. Over to you, Dr. Barana.
Good morning. Thank you very much, Chairperson Madam, for the kind word of introduction. And I would like to thank Ceylon College of Physicians and Sri Lankan Association of Geriatric Medicine for the valuable opportunity given to talk to you on this topic. It is evaluation and prevention of falls in the elderly. So during this 20 minutes to 30 minutes, I would like to touch upon the basic stuff of falls with a bit of demography and risk factors, and how are we going to evaluate and their preventive strategies and management strategies. And I would like to review some literature regarding falls in elderly. So falls and the related injuries, it's very common, serious problems in elderly, and not only the community patient, older people, it's prevalent in residential care as well as our hospitals. And long-term consequences of falls to individual and the family is enormous, and it increased the healthcare cost. So what is a fall? Actually, it's a sudden unintentional change in position causing individual to land at lower level. It may be on the floor, it may be onto an object. Right. So falls in elderly cause a lot of consequences. Not all falls in elderly cause injuries, but majority can cause pain, distress, as well as minority of cases cause serious injuries. So basically, the soft tissue injuries, lacerations, abrasions, those things cause pain, distress, and the functional difficulties. And a minute amount of people develop, about 2 to 6% of them develop fractures. And out of that, hip fracture is the worst thing, because we see a lot of patients, elderly, coming with hip fractures, and we are spending a lot of money and doing surgery within 24 to 48 hours. So if we prevent, we can actually improve their morbidity, as well as we can give a better quality of life. And obviously, it causes a lot of mortality, as well as there is a lot of psychological problems, because when an elderly person fall once, definitely it causes fear. So fall phobia is a major thing which actually we are not addressing. So fall phobia, anxiety, cause loss of confidence, as well as because of that elderly, they prefer to stay inside, and ultimately social isolation, social handicap occurs. And independence, as actually previous speakers said, independence is the most important thing. From starting from childhood until we die, we would like to be independent. So if we prevent falls, actually we can maintain the independence till they die. Right. So what are the types of falls? So basically we see a lot of accidental falls. If we take about our wards in the hospital, the accident and emergency departments, we see young people who are coming from fall from the height, or are the various sort of accidental falls. So these young patients are low risk. What has happened is they either faced environmental hazard, or they actually, due to external mechanical force, or object, they develop this. But when we talked about elderly, most of our elderly patients who present to us, they just fall from their standing height. While sometimes when they get up from the seated position, or just when they walk into the toilet, they just had a fall. So thinking about elderly, there are two types. There are like anticipated falls, where the patient has high risk factors, which can be identified in advance, like patient with Parkinson's disease. We know they have mobility problems. We anticipate falls. And another type of elderly people, like strong, robust elderly people, otherwise they manage and they are low risk, but sometimes they fall, like syncope, seizures, or stroke, and that is unanticipated manner. So the relatively low risk elderly also develop falls due to these sort of things. And thinking about the accidental and mechanical falls in elderly, so they do have some, about 25% of community dwelling older people have experience like slipping, tripping, or stumbling cause fall. But if you think about after the fall, if you really think about, if a younger person experience similar thing, whether that person will experience similar sort of fall, probably not, because these patients, the elderly, they are actually facing some mechanical stress or thing, and ultimately they are falling because they have they are having their deficiencies. So external factor seldom cause fall in elderly, because I can remember when we were doing the foreign training. During the first straight ward round, if we say present to the geriatrician telling, look, this older gentleman who presented with mechanical fall, they were really upset. They said, most of the geriatrician in UK said, there's nothing called mechanical falls. There's no single cause like mechanical. So these mechanical forces add on to the intrinsic deficiencies of the patient. Right. So what is the prevalence? So falls in the community, like 1/3 of older people in the community above 65, they actually experience at least one fall per year. About half of the 80s, same, they experience fall. About nursing homes and the hospitals, the rate of falls are almost like 3 times higher. As well as the people fall once, the repeated falls occurs about half of them, 50 to 60%. And the recurrent falls are like, is defined as more than 2 falls for 6 months. So either recurrent falls or they have repeated falls during the course. Why? So actually we had the symposium of frailty, sarcopenia, and now we are talking about a condition, geriatric syndrome, where we can take all this together and see why these people are falling. Because when we are getting older, there are physiological changes of aging. So there are neurological, there are visual, as well as decreased muscle mass, sarcopenia. So we experience a physiological changes like increasing reaction time, decreased proprioception, the visual change, and impairments, which is part of physiological change. And gait changes with the time. So when we are getting older, our gait speed is slower, and our gait stride, length, arm swing, those things change. And sometimes so it is the flexion to the head flexion to the forward, and the increased lateral sway. So the changes, the physiological changes with aging about the gait as well as other systems contribute to falls. And other disorders. So as we are getting older, as said previously, so we get some disorders, we got health conditions. So the osteoarthritis of the knees or cause joint instability, pain, the weak quadriceps. So other than the physiological changes, the pathological processes occurring during the aging process add on to the risk of falls. So falls is a geriatric syndrome. So as frailty, what it reflects. So a fall in elderly reflects the diminution of the functional reserve. So as frailty is like multi-system diminution of reserve. Here, the mainly orthosis, musculoskeletal, neurological, again, multi-system functional reserve depletion. As well as with that diminution, these people are more vulnerable to the vulnerability of mechanism to deterioration occurs with accidents. Even a minor trip, minor slip can cause fall, as well as adding acute diseases, active diseases, even simple drug, adding a new drug can cause fall. So we are talking a lot of frailty, sarcopenia up to now. So it is why we added falls as a part of this symposium today, because frailty and falls are always interrelated, and both share common pathological mechanisms and common risk factors. So it's, as said previously, the advanced age, functional impairment, low activity, low muscle strength. So all these things, risk factors add together. And both falls and frailty result common adverse effects. Yet falls and frailty are distinct geriatric syndromes. So frail person can develop falls, and recurrent falls can lead frailty, but these are common. So the management strategies that we have to take frailty and falls. We can't separate. So this graphic demonstrate. So frailty leads to falls, as well as it causes the catastrophic events, as well as you can see frailty, reduction of function, as well as Both frailty falls may lead to common pathway of hospitalization, institutionalization, and death. So if we modify frailty, if we look the causes for falls, and if we use the strategies to improve or evaluate and prevent, we can improve the patient. Either falling can be improved as well as frailty can be improved. So the falls is basically complex interaction of, as I said previously, it is biomedical, physiological, psychological, as well as environmental factors. So it's graphically represented here. There are intrinsic factors where patient is having and extrinsic factors. So age-related changes, impaired vision, medical conditions are intrinsic, and extrinsic factors are medications, improper use of assistive devices, environment thing. So I will tell some things detailed. So these are some just the detailed version of the intrinsic factors. So poor mobility. So poor mobility, increased risk of as well as frailty, as well as falls, everything. So mobility is important. So cognitive impairment, the patient with dementia, so judging when the patient is walking, the judgment is poor, unable to think, where are there any objects, obstructions, those things will impair. So cognitive impairment. So continence problems. So we have seen a lot of patients coming at night following a fall while they are rushing to the toilet, because these sort of patients may having overactive bladder. So other medical conditions, sensory deficits, and today we repeatedly talk about nutritionals, importance of nutrition. So poor nutritional state and emotional things are intrinsic. So extrinsic, our favorite things or management strategy for any patient is giving a drug. So giving medications to elderly cause a lot of problems. So some drugs, like even the Parkinson's patient, starting Parkinson drugs can cause postural instability, because those anti-Parkinson drugs per se risk factor for postural drop. And we are famous for polypharmacy. We give a lot of drugs with the evidence-based medicine. And the other things, actually, we discussed the environmental hazards, lack of exercises, those are some extrinsic. So environmental factors. So thinking about the lighting, glare, uneven flooring, rugs, and thinking about our parents, actually, our parents or elderly mostly live with extended families. So there are small kids, their toys are all the way, everywhere in the house. So these simple things can increase the falls. And these are some medications. So psychiatric medications are famous drugs or sedatives to cause falls in this paper. Right. So studies on falls, actually, since like 1988, there are a lot of studies looking at the falls, causes for falls. So this study, they looked at the causes for community, mainly falls in the community. You can see mainly environmental and accidental. Accidents and environment has a lot of bearing of the community falls. The other things like medical condition, weakness, balance, gait, acute infections, illnesses, those things also come to about 30% when we take together. And the community, the most important thing, if you think about community preventive programs, as Dr. Dilha said, so we have to get the involvement of the community as well as the family members, as social workers or community leaders to improve the community status to reduce the falls in this patient. When we take the residential care or hospitals, the patients coming to the hospital for the different illness, while patient in the ward will sometimes fall and sometimes ended up in like intracranial hemorrhages and death. So why people have more falls in residential care or hospitals? Because this study showed the generalized weakness, deconditioning is the most common cause. So environmental, the hazards are low, but the orthostatic hypertension bears a lot. So if an elderly person in our ward we have to always look after their hydration, their nutrition, and see the medications they are on, because orthostatic hypertension contributes a lot of percentage in these patients in hospital-associated falls. Right. So I will just touch on how are we going to evaluate. So evaluation, first, who are the people we are going to evaluate? So older people who presented due to fall, definitely they should be, they should, if this patient come to a surgical ward, or probably they ended up in orthopedic ward, but our responsibility to see why they fall. Then the people who had recurrent falls during the past year, and the any person, so those above two patients who had already fallen. So our importance is to prevent secondary falls. So the secondary prevention strategy is important. The other category, the people who hasn't had any fall yet, but the postural instability, mobility problems, balance problems. So that is primary prevention. So primary prevention is important in these patients. And thinking about the hospitals, we mainly focus, when a patient come to us, we mainly focus on the medical diagnosis. The patient coming with pneumonia, we treat pneumonia, but next day patient may have a fall. So if as I said previously, above 65, about 1/3 of people fall in the community. So in the people admitted to a hospital, we have to think about, like, above 65, they are having risk for falls. The other type is even younger than that. If they have cognitive impairment, continence problems, if they present with seizure, they present with stroke, or if they are having visual impairment on multiple drugs. So these people are candidates for assessing the falls risk. So evaluation of falls, it is multifactorial risk assessment. So as I said previously, so the intrinsic, extrinsic environment, there are a lot of factors. So importance is to see what are the factors. So we have to look into the history, falls history, we have to look the functional ability, we have to assess the mobility, the vision, the osteoporosis risk, the urinary incontinence, the home hazards, as well as neurological, cardiovascular, and the medication review is very important in evaluation. So multifactorial risk assessment is the key in this sort of patients. So thinking about the fall, we have to think about location, circumstance of the fall, associated symptoms. So near falls, the medications, a lot of elderly patients, they use drugs, even from Ayurvedic medication, they use drugs from pharmacies. So we have to ask, what are non-prescription drugs also? So the history, we have to mainly address those aspects, as well as we have to ask fear of falling, whether patient is phobic, because that is very important to prevent future falls. So examination, routine examination, cardiovascular, musculoskeletal, neurological, standing and lying blood pressure, very important thing. We rarely do this. If a patient coming with fall, lying and standing blood pressure, look for postural drop is a must. Then formal gait assessment and time test, go up test. These things actually discussed previously, as well as delirium screening, and as well as the look for injuries, important. So investigations, basic laboratory investigations, cardiovascular markers, ECG, troponins, echo, and the signs of infection, dehydration, drug toxicity, those things should be checked in investigations. The management. So falls is due to multiple risk factors. So first, to prevent falls, we have to identify risk factors. So after identification of risk factors, the important thing is to intervention with multifactorial intervention programs. As frailty, falls also same. After identification, we have to look into specific risk areas, and we have to manage. So strength and balance training, as extensively discussed, home risk assessment, home assessment and intervention, and vision and visual, if there's any problem of vision, providing glasses or cataract surgery, and medication review and modification of drug. Those 4 areas, very important while treating for the diagnosis. If a patient may come to you with sick sinus syndrome coming with falls due to the cardiac syncope. That patient needs specific diagnosis and management. So cardiac syncope, sick sinus syndrome patient need the phasing. So other than that is the definitive diagnosis, but prevent more falls, we have to look other and improve the strength, risk, the home hazard, vision, those things also. So while working for particular diagnosis of falls, the other risk factors to be addressed in hand to improve the quality of life of a patient. And I just go through this, the recent, the meta-analysis, systemic review with meta-analysis, which analyzed about 41 trials with almost 20,000 participants. This is they actually look into the multifactorial interventions for preventing falls in people in the community. So the mean age of participants were like 72 to 85, and what they were looked at was rate of falls. Rate of falls or the intervention group, the mainly intervention based on exercise programs plus risk factor management. The conventional group, they just conventionally manage their disease conditions. Like, so when they look at these trials, the rate of falls, that means number of falls per year, is reduced, is very significant in the interventional groups in these various studies. And if I say the porous plots here, then you can see the effects of multifactorial intervention of rate of falls. There are like heterogeneity of all these trials, but there's a significant benefit of a multifactorial intervention for rate of falls. And the number of falls, like number of falls in the community, the people sustaining one or more falls in the community, because this is not like time limited, but it has shown, again, there is heterogeneity of trials, but there is a significance shown in this. So they conclude like there may, this sort of multifactorial intervention may prevent sustaining one or more falls in these people. As well as thinking about the recurrent falls, that means time, like 6 months or 1 year. This follow-up went for 1 year, and what they looked at, the time and number of falls, like the recurrent falls, again, that shows the benefit. But as it's because of this, it's just touching the one, they say the effect of these interventions may prevent falls in the patients. So it is like evidence-based. So rate of falls, the recurrent falls or number of falls, and the other things like fall, those things clearly showed a benefit. And in these studies, if you see the number of this, the table, so initial three things, about 10,000 to 13,000 participants in those trials. But when going down, the risk of fall-related fractures and the hospitalization, the medical attention and quality of life, they are about less number of patients, has not shown a benefit. So what we need is we need more trials as well as more systemic review with the high quality data to see the benefit of those. But what we know so far, the multifactorial assessment, multifactorial intervention is beneficial to preventing rate of falls as well as recurrent falls in the elderly patient. So in summary, the falls are common in elderly, may lead to injuries and decline in function. So falls and frailty, sarcopenia, all interrelated. So the evaluation is basically identification of multiple risk factors and improving the gait and the gait and home assessment. And exercise is an essential component which is extensively addressed today. Nutrition is important, and rather than addressing a single factor for falls, so multifactorial risk assessment and multifactorial intervention, which is like one of the gold standard in geriatrics, like comprehensive geriatric assessment or for frailty, like multifactorial risk assessment intervention is improve the prognosis. So tomorrow, afternoon, like 5:30, there is a teaching capsule on assessment of falls, and I will do more case-based falls risk assessment, scenario-based lecture on that particular thing. So I invite you all to join tomorrow 5:30, the teaching capsule 4, where it will be like more case-based discussion for about 1 hour with the assessment of falls. Thank you very much.
Thank you, Dr. Parana, for covering falls, which is an important topic in geriatric medicine, covering that efficiently. May I now call upon all three speakers on stage for the question and answer session, Dr. Lasanta, Dr. Dilha, and Dr. Parana, please. We have a question for Dr. Lasanta. Can you please elaborate on the effects of polypharmacy on frailty? And are there specific drugs that contribute more to frailty?
Thank you, Dr. Achala. Actually, it's a very important question. It is regarding the polypharmacy. So the frailty is deemed related to polypharmacy. We traditionally tell that polypharmacy is if somebody is taking 5 or more than 5 tablets, 5 categories of tablets, it is polypharmacy, but there are some other thoughts also, the appropriate and inappropriate polypharmacy and all. But when it comes to frailty and polypharmacy, it's independent. Polypharmacy is independently related to the development of frailty. There are several ways that we can think of, we can formulate. If somebody is taking more tablets, that means that person does have a lot of comorbidity. So that is the comorbidity and functional disabilities, and all these things are part and parcel of development of frailty. The other thing is somebody is, especially elderly, with their depletion of the physiological and biological reserve, they face many pharmacokinetic and pharmacodynamic deficiencies when it comes to the metabolism of drugs. So if somebody takes more drugs, they face many side effects. For an example, if simple codeine phosphate can lead to a dramatic changes in their cognition and delirium. So therefore, the developing side effects, making them more vulnerable to develop frailty, as well as the surrounding comorbidities, which may need many tablets, also contribute to the frailty. Therefore, the polypharmacy is an independent risk factor for the development of frailty. On the other hand, that particular doctor is asking whether there are specific drugs can contribute to frailty. The answer is that any drug can contribute to the side effects and development of frailty. But especially centrally acting drugs like antipsychotics, anti-epileptics, antidepressants, all these drugs, centrally acting drugs, causing many more harm to the elderly patients. So we have to be very careful when we are prescribing those drugs. But as a whole, any drug can cause frailty and can contribute to the development of frailty.
Thank you, Lasanta, for that illustration. We welcome more questions. We still have a few more time to spare on questions.
areas? Sort of, is there sort of like with the elderly secretariat pushing forward, various things pushing forward, what changes are sort of, are they enforced in making environment safe for elderly people, who, especially for those who are frail, like for instance, like ramps, etc.
Actually, the chairperson is more suitable to answer this type of question because she has done a diploma in gerontology and she's very competent on that area. But just to comment, I would like to say that when developing new cities, new buildings, there are regulations and they have to conform with the standards. And I think in the cities, ramps and Edelica friendly facilities are a must to get the plans approved. That we are well aware. And the National Secretariat for Elders have actually developed guidelines, and then there's a SLS standard document for Edelica homes. Actually, at Kalubovilla Hospital, we have trainees, and we went through these guidelines because they're very important. When the SLS, just like the SLS standards, there are other standards for the elderly care. It's not SLS, but standards for elderly care, which need to be practiced. Where, for example, if you are building an elderly care home, at least you need a number of perches, at least more than 40 perches in a city, and in a more rural area, more than 1 acre. Such guidelines are there. And for development of cities, also there are guidelines, but I'm not very competent to comment on those. But these are currently underway. I think the Ministry of Social Services and the Ministry of Health are working in a combined way towards these goals. Achala can comment further.
In Sri Lanka, I don't think it's highly implemented, but WHO has introduced a special manual for elderly friendly cities concept. So in that, for public transport and in public buildings, for elderly friendly access has been all described. I think in one of the cities in Sri Lanka, they have implemented Monragala, but in other cities, I think they still have to work through it. But in time to come, we will try to liaise with the Ministry of Social Services and National Secretariat to look up that aspect of geriatric care as well.
Actually, I mentioned the Decade of Healthy Aging action plan, so that we are all part of that. Sri Lanka is also part of that, especially in the Southeast Asian countries. The WHO will be guiding to develop standards in elderly care during the next 10 years, because we are going to see more and more elderly people in the community.
This is a passing comment. Dr. Lasantha nicely spoke about the Edmonton Frail score and the pictorial depiction. And you mentioned that that's used as a part of pre-operative assessment. Can that be used as a form of quick form of detecting frailty? Because I have been talking about it in public, as well as I have been telling at certain medical forums also. Imagine where your parents stand, or imagine where you stand, or imagine somebody who is elderly stand. Can we use that as a sort of a quick way to identify frailty?
Yes, of course, Jan, you can use. But it was initially the main investigators of the Edmonton Frail Scale. The investigators mainly concentrated on the pre-operative assessment of elderly people. But of course, you can use, there is no harm, even all these nine components in the Edmonton Frail Scale all components like cognition, disability, functional ability, health, everything was addressed. So it is a very comprehensive sort of tool. So you can use. There is that is, of course, it can be used.
We have a question we received earlier on. This is about metformin use and frailty. Is there any evidence to say that metformin is useful in frailty?
There is no. I could not see during my. I read a lot of things before the preparation of this presentation, so I could not find any sort of evidence.
So in the absence of any further questions, now I would like to call upon the three speakers to receive the token of appreciation from Ceylon College of Physicians. Can I present my token of appreciation to Dr. Santa Ganewate? I would like to conclude the session on geriatric medicine. Now the closing remarks will be delivered by Dr. Ananda Vijay Vikrama, President of the Ceylon College of Physicians.
Good afternoon, ladies and gentlemen. It's a great pleasure to talk at the end of a successful workshop. And it's a great pleasure to have this inaugural pre-congress workshop with preceding our inauguration on this very important topic. And I'm thankful to the Sri Lanka Association of Geriatric Medicine for collaborating with the Ceylon College of Physicians, especially at this juncture, to have this workshop. And on behalf of the Ceylon College of Physicians, I wish to thank all the resource persons as well as the participants who participated online. It is really nice to have a crowd in this, in spite of this difficult circumstances we are in. Wish you all the best. Thank you.
Thank you, sir, for that, the closing remarks. Ladies and gentlemen, we come to the end of this pre-congress session, and we would like to invite you to join us again tomorrow and day after in the main conference. There's a wide array of activities, breakfast capsules, small feeds, symposia, plenaries, etc. And I urge you to join us because it is indeed a wholesome program. Although we are not able to meet physically, we ensure that the content and the academic content that is there will be in par with other years. And we would like to inform you, invite you to stay with us throughout the next 2 days. Thank you. All the best.